One. Please start, sir. We are live.
So, good morning, everyone. Welcome to today's symposium on PDA. First of all, I would like to thank all our faculty from India and from outside India. Dr. Kiran More, my colleague, he is there with me. Dr. Rajesh from Ranchi. Dr. Dinesh Chilla, he is there with us from Hyderabad. So, and I would like to thank our tech support who's providing the platform for this symposium, and it has been sponsored by CIPLA. So I'd like to thank the CIPLA team. So in next 2.5 years, we will cover, see, the PDA itself is a very big topic. So we cannot go into every nick and corner of PDA and discuss all of the things, but we will try to bring up all the major issues that and the controversies in clinical management that goes treating PDA, or some people they think they don't want to treat PDA. One, how to diagnose PDA, and the good part of this symposium will be that all the echo indices, the major one that we do, we will discuss. Along with that, there will be a live demo of the same. So before starting, and I would like to share a few things regarding our academy, that is NfECHO and FOCUSin Academy. Are you able to see my screen, everyone? So yes, this is the plan of the day. So first we will start with Dr. Kiran. He will discuss in short regarding the hemodynamics, anatomy, and physiology that has been related to PDA, and a bit of treatment aspects. Then I will discuss the functional echo indices that we do and the echo. Dr. Kamal will do the live demo of all these parameters. So Dr. Arvind Sehgal will be there joining us from Sydney with some treatment options regarding PDA. Dr. Yogen Singh will discuss. He has got a lot of experience regarding the surgical closure and device closure of the PDA. He was in England, now he's settled in the US. Then in the end, we have a very interesting panel, which is to be moderated by Dr. Venkat from PGI. And we have very senior faculty from Ranchi, Dr. Rajesh Kumar and Dr. Dinesh Chilla from Hyderabad. So they will be talking and discussing regarding the clinical aspects. Suppose if the echo is not there, what do you do? And suppose you have a hemodynamic issues, you want to get the hemodynamic assessment. So Dr. Sujit Madan from Jalandhar and Dr. Tejo for Fernandez Hospital, Hyderabad, he will be discussing about that. So I will take another 1 or 2 minutes to just introduce and tell you regarding our academy, that is the NfECHO Academy based in Surat, and along with FOCUSin by Dr. Kiran More in Mumbai. We have been running two kind of batches. One is the 6 months of batch. 6 months batch, there are two types: online, that for 6 months with demo and all the sessions, 2 classes in a week. We do online sessions for 6 months, and 6 months time is being kept as per the PCPNDT requirements. So once you complete 6 months of course, you get the certificate, and that makes you eligible to get your name registered in PCPNDT. If you combine that with the physical hands-on training, 15 days at 1 week at Surat and 1 week at Mumbai, we do this hybrid courses, and this is something which is very hot favorite, the hybrid one, because it gives you an add-on flavor of in unit. You be there and you do the echo on the baby, sick babies. 4th batch is running from Jan 2024. 5th batch, which we will be starting from July 2024. If you scan this QR code or you send us a message on this number, so we will get you registered for the course that is starting on July 2024. And the other course, what we do is the regional courses. The first batch is going on. So we have in Jalandhar in North, for the North region, the PMG hospital. In South, we have Rainbow Hospital as our center. And then in the East, we have Rani Hospital, Ranchi, headed by Dr. Rajesh, and Rainbow Hospital headed by Dr. Dinesh Chilla sir. So there the faculty is being trained, and we do 2.5 month online sessions, and then 2 days in a month. In total, 4 days in physical hands-on training. You need not come to Mumbai or Surat. It is at your very much, it is near you in your zonal centers. You can do that. And many of our trainees that have been involved in our courses, now they are the faculty in our workshops and in our CMEs and symposium, as you see. And we have been doing a lot of international neonatologists have been getting trained. So many people from Bangladesh, Indonesia, and in Dubai, and recently we had a group from Qatar. So Qatar group was here with us. They are all senior neonatologists. So we have got a lot of people from all over the world who have been coming and getting the hands-on training with us. So anybody is interested can scan this QR code, or you can message on this number. So I hope this gives a kind of outline and kind of platform which you people can use if you are interested in learning the neonatal hemodynamics, point of care ultrasound. So now we will start with our PDA journey for today. And for introduction of everything and anatomy, physiology and everything, we have Dr. Kiran More. He is a consultant neonatologist who is settled, who is based in Mumbai. Now he has got this, you can see the background in his picture. There is his new hospital, which is a kind of offshoot of, or a center which is accredited by Hospital 6 in Toronto. And we are both fortunate enough to get trained from that place. He was a consultant neonatologist in New Zealand and then in Doha, Qatar. And we are fortunate to have him in India with us. And I'm really fortunate to have him as my colleague, my partner, and everything for this training platform. Over to you, Dr. Kiran.
Thank you, Dr. Mohit, for a generous introduction. So, good morning, everyone. Again, welcome to this online teaching platform, and we have been trying to do some symposium in between to share our knowledge, and we were overwhelmed with the responses we got from the previous sessions, and today's topic is a very topic of favorite topic for all the neonatologists, and specifically those who are interested in the hemodynamics. So let's see again in this next 2, 3, 4 hours whether we can do justice to this topic. Again, as Dr. Mohit mentioned, it's very hard to cover. We can have a whole conference for this topic to go into nitty-gritties and intricacies of management. But today we will just try to stimulate you with all the basic principles, physiological understandings, and hemodynamics related to it. And then how do you assess and take a decision based on individualized approach. So again, I was prior to this. So bottom is the MRR Children's Hospital where I'm currently working, which is one of the largest in this region currently, and we have a good sort of quaternary NICU here. And on the top is the alma mater for a lot of us, the Wadia Children's Hospital, where I was heading the NICU prior to this attachment. So in last 50 years in neonatology, basically there's a lot of evidence being published in the neonatology and also in the topic of PDA, with multiple RCTs and meta-analysis coming up and giving us some kind of a guidance. As if you just do a PubMed search, you will hit about 1,300 searches on PDA and more than different 70 to 80 types of RCTs. And still this topic remains a bit of a debatable topic despite so much of evidence. Now what has happened is we are trying to move towards practicing evidence-based medicine, and that is what we preach and practice. But the art of medicine seems to be declining nowadays, which when we studied and we were residents, we would try to focus more on sort of physiological understanding, and that seems to be declining. So we have to understand that every individual is different, and we have to tailor-make the management for that particular individual with the background of the evidence. But we should not forget the physiology, and that is the emphasis of today's talk. And what has happened now with addition of technology, there's a lot of confusion, so we have a lot of parameters now. We've got echoes, and we've got non-invasive cardiac output monitors, the needs monitors, and the other multi-para monitors. So poor clinician is flooded with a lot of information which he needs to process and then come to a conclusion. So we often get confused, especially the newer consultants who are coming into the practice often get confused, and we don't know which way to go and which one to follow. So let's see if today, in this next 3-4 sessions, we can at least make this confusion a little bit clearer, or we might confuse you more. Because I think the less you know, less confused you are, and the more you know, your mind becomes more confused. So PDA is a conundrum. Conundrum is like a puzzle. So basically, treat or not to treat has been like a dilemma going on for last many years, and the pendulum is swinging up from aggressive treatment to completely no treatment to maybe selective treatment. And we are debating which is the correct way, and sort of most of us have figured out some middle way which works for them. But there is a lot of variations in the practices in the management of PDA, which we can discuss in the today's panel. So when we talk about this PDA conundrum, these are the aspects we generally talk about. So, what is actually a PDA? When do you call it is a patent, and it's a pathological and not a physiological event, and why we need to treat it, or when is the ideal time to treat it, and what are the options we have to treat it? All these issues we have addressed in the book chapter we wrote along with Samir Gupta, and some of this we will be covering in today's talk. So historically, if you go back, the association, there has been very strong association of just observations of PDA, been increased incidence of neck. Just presence of PDA was associated with increased incidence of the neck, or closure of the PDA was associated with less incidence of the neck. And if you read this RCT now, you will laugh, that it's an RCT for trial of prophylactic ligation of PDA for babies less than 1 kilo. So the current residents, if you hear this was kind of a RCT somebody conducted, you will laugh at it. But this is just tells you that this is kind of the threat PDA was when in the early 80s, 90s, and people were worried that if PDA ductus remains open, it might be disastrous. So it's better to close it early, either by drugs or by early ligation. And these kind of studies have shown that the incidence of NEC and the mortality was less when you ligated babies early. Obviously, we know now this is not something we would practice or think about, but this is just to show the perspective what the clinician's idea or the perspective was in the early about 2 decades ago. Now, is PDA really a problem? So again, Sharp's Neuri's this publication is a good sort of observational study which actually highlights the importance of the PDA, and he's shown that large PDA on day 3 of life, especially babies who are less than 20 weeks of gestation, has 3-fold increased risk of odds of death or severe morbidity, about 4 times increased risk of intraventricular hemorrhage, almost 4 times increased risk of BPD and NEC, and 8-fold increased risk of mortality. Now, although this is an association and observation, this is something which was alarming, and this is what everyone is worried about. But then, despite all that aggressive or this approach, now over last 10 years or so, a lot of people have moved, especially like sort of the world is getting divided between the hemodynamic and non-hemodynamic community. And again, no bias in that, but the difference of opinion comes from the different practices and also the evidence. And people have moved completely on the opposite sometime to go hey doc, please leave the PDA alone. It's not a problem, as you are highlighting. It's not the end of the world if you have a PDA, and you can just manage it conservatively. And people are moving towards an approach which is called as therapeutic nihilism. We are trying to do less and trying to just conservatively approach and treat only if it's really indicated. So whether even that is correct approach or not, that is something we need to discuss and talk about today, and we'll have more highlights on this in the panel. And the suggestion is probably, when you have to have an interim approach to handle the PDA. So what will happen if, why this, why this shift has occurred? I'll just close this. Yeah. So why this shift has occurred? So there are a few reasons for this shift from this aggressive approach to a very conservative approach. So if you look at the natural history of the closure of the PDA, so if you don't do anything and leave the PDA alone, what will happen? So basically, in the term babies, it will close rapidly. Okay, so PDA is not a problem for the term babies at all, and the almost 96% of the babies, the PDA will close about in by day 2, day 3. Now, if you go and look at the babies less than 30 weeks, where the PDA is a problem, actually, the closure rate is inversely proportional to the gestation. So, smaller or more premature the baby is, the chance the PDA will remain open longer. So, as you can see, in less than 26 days, it is median is 71 days to close. Up to 28 weeks, it's around 13, so about 2 weeks. And by 29, 30 weeks, it is about a week. Now, more than 30 days, it's about first 5 to 6 days, it will close. And even in the less than 28 week, if you don't do anything, most of the babies will, 50%, more than 50% of the babies will end up closing their ductus at their, before they exit the NICU. Now, that is why we say that PDA is probably not the problem in the term baby, and it is probably less of a concern even between 30 weeks and 37 weeks, which are still technically preterm. What we talk about, all this discussion is applicable maybe for all the babies which are in this group, which are less than 30 weeks. Now, again, the additional things that there are more and more observational studies and database studies which are coming up showing us that the PDA eventually closes. So one of these very large NICHD studies of 61,000 infants from 280 NICUs in US, which was published in 2017, and they have shown that nowadays we are diagnosing PDA less, maybe we are looking less, and people are using less of indomethacin and ibuprofen. People are doing less ligations, almost 2.9% or even less than 1% in many units now. And overall in this period, still the mortality has gone down. So despite the shift to non-aggressive approach, the mortality has not changed. And with no increase in major morbidity also. However, obviously, whether it's affecting the long-term outcomes or not, that remains debatable. Plus, the neonatal care has also evolved in this last 10 years, this period which study was published, that we are going more conservatively in the ventilation, we are going to more non-invasive ventilation, use of CPAPs, sort of less, plus more advanced sort of technology, monitoring and managing these babies. So definitely the survival has anyway increase in neonatology across the centers. So whether it's this approach is contributing to it is something is a questionable. Even the another study which highlighted was the largest study was EPIC study. EPIC study has given us a lot of information of prematurity outcome. One of the things was PDA. This was again for 7,000 infants across 19 regions and 11 European countries. And they have, one of the highlighting thing they had mentioned that PDA, the infants treated with PDA were at higher risk of BPD or death, with overall propensity score adjusted to 1.33. However, survival without major neonatal morbidity was not related to the PDA in their cohort. So again, the babies who end up treating PDA, they were the sickest cohort, and they had other risk of developing BPD and mortality. So again, it's a chicken and egg, whether it's treating the PDA, which is causing this effect, or it is just the disease process which is causing the PDA to remain open, and then they end up getting treated. And this is what we observe because these are the observational studies. Again, PDA tolerate trial was one of the largest trial where they conservatively managed and decided to tolerate the babies, and and the outcomes of studies. And again, there was no much difference in the outcomes. But the important that if you do a post hoc analysis in the PDA tolerate trial, the clinicians were allowed to treat the babies as per their discretion. And if they look at the data for treated babies who were, sort of they opt out of the trial, and the observations that these babies were extremely preterm. They were less than median age less than 26 weeks, and in the both the groups, and the observation that those who were treated, the BPD, the composite outcome BPD or need of oxygen was less, significantly less. So again, it is very importantly highlighting that the time has come to selectively target the babies, and probably not all the babies, and especially the babies who are less than 28 and 29 weeks and who is the sickest cohort. So we have to select these babies based on the clinical criteria and the echo criteria, and probably targeting them might help you to decrease the morbidity and mortality. Again, another reason for shift is that these babies, the most of the recent trials and the meta-analysis did not show any difference. So even if you look at any treatment of the PDA or medical or surgical prophylactic approach or all the treatment approach, this is one of the meta-analysis, and sorry, it looks like a busy slide, but except for reducing the ductal patency, which you achieve, there are no other differences which were seen by treating the PDA early or aggressively. The other reason for this conservative approach is that ligation may not be very safe, and there are a lot of complications associated with ligation. Also, one of the studies, meta-analysis we published about 10 years ago, there is an increased risk of neurodevelopmental outcome, BPD, and severe ROP in the babies who undergo ligation. Although it is associated with the reduction of mortality, so there is a trade-off. You reduce the mortality, but you end up having a significant issues. Plus, we know that surgical ligation has its own consequences, immediate consequences because of the approach. There's especially the thoracotomy was the way to go forward in the earlier days, and still in many centers. There are a lot of these posterolateral thoracotomy related complications because of the nerve damage. There is a the immediate complication like pneumothorax, chylothorax, respiratory instability, and also some other complications because of the ligation of the recurrent laryngeal nerve, like vocal cord palsies and other and henceforth. So there's a lot of scare about subjecting this baby for surgical ligation, and that's why this approach is going down and down and down as the years have progressed, and the device closure approach is coming up, which again we will be talking, Dr. Yogin will be talking about it. And lastly, again, I did mention about the trials, Baby Oscar trial, the Benedictus trial, and the other Australian trials. We were hoping to get some kind of answer or guide what we should be the better approach. But unfortunately, the early approach or sort of preclinical echo-based approach has not significantly shown to make a difference in the outcomes, especially the long-term outcomes. And again, we are sort of stuck in like a Groundhog Day movie. If somebody has seen, the actor starts all over the day again and again. He's preparing for an event. He starts his day and again get in a circle, and his days doesn't progress. So similarly, last 20 years, despite many trials are coming up, we haven't got a very clear-cut approach, and we are sort of stuck in that dilemma or a conundrum about what is the best approach to manage the ductus. And again, we will have a lot of this discussion in the panel at the end, and we'll see how different people are approaching the PDA. But there is a reason why these trials are not able to answer. If you look at all the trials, there are a lot of, again, intrinsic biases, which could be the reason why we are not able to get the answers. First of all, the many trials, because of the numbers they could recruit, selected older gestation babies. They included babies less than 32, or sometimes even some trials included even 34, where we just saw that PD is not the problem in these babies. So you treat or not treat doesn't make a difference. And so there is a lot of bias, and postnatal age also sometimes is considered older. There is no definite sort of a standard sort of indication which these trials have followed. Plus, echo criteria which were followed are quite different, and there is no significant comprehensive HSPDA definition has been looked at which Dr. Mohit will talk in more detail. So there are about 10-15 criteria which actually tells you, with the confidence that this ductus is probably significant. But most of the trials have looked at maybe just the diameter and LAO ratio, which are not always significant. So again, there is a bias there. Nobody has looked at shunt volumes and end organ damage. What is the effect of the long-standing PDA on the duration of this PDA? How much is the shunt volume which might affect the lungs? And all those things nobody has considered. Again, the trials don't talk about the respiratory status, because in clinical practice we do speak a lot about this, right? That what if the baby is ventilated or is on CPAP or is on NIV or just oxygen. Our management approach do change, right? So it's just the presence of PDA and absence of PDA is not important, but what is the current clinical status is also important, equally important. And there is a lack of understanding about the physiology and mechanisms. And when you do more comprehensive echo assessment, you get a more idea about what's exactly happening with the babies and whether you can justify certain clinical features based on the PDA, and then you choose to treat rather than just sheer diameter or just like a protocol based approach. And again, a lot of these trials had heterogeneous group, mixed group, which again confounded the result. And the last but not the least was the high rates of open label trials. So you saw in the PDA tolerate trial also, the open label incidence was high, even in the Bediductus or the Oscar trial also, almost 15, 20, 22% was the open label treatment, and which again diluted the results. And that is the reason, that could be the reason we did not get a very clear-cut answer, and the trials have shown no difference with either approach. So this comes to a point that whether we consider PDA as a dichotomous entity, which many times our residents who are excited and those who are learning the echo, they find the PDA and they get excited. Okay, this baby has PDA, I want to treat. So is it a dichotomous entity where whether we are talking about PDA, yes, present and absent, or should we consider that I would like to see this PDA, what is the happening in the baby physiologically in presence of PDA, whether it is beneficial in some way, like we have a congenital heart disease or ductal dependent lesion, then obviously PDA is essential for this baby. Sometimes there is a PPHN where RV is under strain and the PDA might be beneficial for that baby. So just presence of PDA doesn't mean anything. I would probably help and leave this PDA alone if it is beneficial. Sometimes PDA is present, but it's a bystander. It's an innocent bystander. It's not causing any clinical effect. Like we see many babies are clinically, they're feeders and growers and the PDA is still there and the echo parameters are not changing. And that's like an innocent bystander. Then I wouldn't approach and aggressively treat or, subject the baby for NSAID side effects. So it's an innocent bystander. And I have to just identify if the baby is the PDA is harmful for that baby, and the root cause of all the evil, whether you can explain all the hemodynamic effects of the PDA based on your echo and clinical criteria. And those are the baby I would like to identify based on the echo and then treat. So coming to the physiology, how the PDA physiology changes. So I think we all are aware of what is the importance of the PDA in the fetus life, and I'm not going to repeat that. But PDA, all the three levels shunts are very essential in utero life. So PFO, ductus venosus, and the PDA. And we know that PDA will help to bypass the lungs and help the systemic circulation in utero. Now, once the baby is born, and we know that in utero, the pulmonary pressures are very elevated, which helps the PDA to direct the blood circulation to systemic circulation, which is normal in the fetal physiology. So pulmonary pressures are very elevated in utero and just at the time of the birth. So the first thing when the baby cries and take breath, the lungs get opened up and the pulmonary pressures will drop, and they should decline immediately or within few hours, depending on the gestation. So term babies transition well. In preterm babies, where the PDA is a problem, less than 30 weeks, there the pulmonary pressures tend to transition low. So it takes like a day or two for the pulmonary pressures to come down. Now, initially, the ductus might be bidirectional. It might be bidirectional because of the elevated pulmonary pressure, and then eventually it will become like a left to right shunt because the pulmonary pressures are now transitioned below systemic circulation. And then actually the PDA problem starts. So whenever we talk about the PDA, the prerequisites that the PDA pulmonary pressures have dropped and baby has transitioned, because all this physiological effect which we will be talking about PDA, they are of left to right shunt, and right to left or bidirectional shunt generally don't cause problem related to PDA. They will have problems related to PPHN or transition physiology, but not related to the PDA. So by day 1 or 2, the PDA will become left to right, and then either it will close or it will remain persistent for next few days. And then it will start having its effect. The very first effect which will you see that the moment baby's transition, that your diastolic will start dropping. So you will get hypotension. So your diastolics will be low, and then your means will be low. So low diastolic and then low mean will be the presentation. And then again, the question comes whether you treat that hypotension, that number, is the baby really clinically symptomatic? Is there an acidosis build developing? Baby is going into shock. What number you will treat? That something remains controversial, and which we can again discuss in the management. But we are moving away from just treating the number. If hypotension is there because of presence of PDA and there is no chemical criteria affected, no clinically, there are no like poor perfusion signs and base excess is normal, lactate is normal, then there's no need probably to treat hypotension. But baby will present with hypotension, which you need to monitor. Then if the ductus remains open and the lungs get flooded, and suppose you extubate this baby, suddenly the pulmonary pressures drop, babies might end up with pulmonary hemorrhage. And by day 7, the risk of IVH also remains with these fluctuations happening in the blood pressure with hypoperfusion, reperfusion injury, and IVH can occur. So that is what the physiology most of the babies will follow. And if by day 28 the ductus doesn't remain open, then it will have all the other effects of flooding the lungs like BPD related pulmonary hypertension, etc., and the cardiac effect, which we'll talk in the next few slides. So I've got 5-7 more minutes, right? 10 more minutes?
Yeah, around 8 to 10 minutes.
8 to 10, right. So the physiology in presence of shunt is different than the physiology of a normal child or an adult, because the shunts are playing the role. So generally we presume that right-sided cardiac output will go to the lungs and left side will go to the systemic circulation. But in presence of PDA physiology and the PFO physiology, the systemic blood flow coming from all over the body, especially upper and lower part of the body, will be coming to the right atrium, but it will also get blood contributing from the left atrium through the PFO. So because of that, the right ventricular output is contributed of systemic blood flow and the atrial shunt. So you might have a PDA with a high RVO, and you still might be systemically underperfused, but the RVO might be high because of the high shunt volume if the PFO is large. So again, it doesn't tell you exactly what's happening with the systemic circulation. And what is happening on the left side, the left ventricle gets blood from the left atrium, which is predominantly blood coming from the lungs. But in presence of PDA, the blood gets shunted across the PDA and goes to the lungs, and then increase pulmonary blood flow and blood returning to the left side of the heart, causing the LA to get dilated and then LV to get dilated. And that is why the LVO is effect of the pulmonary blood flow and also the ductal shunts. Okay, so more the blood ductal shunt, more will be the LVO. And that's why the cardiac output goes up in LVO, and it keep going up and till the LA-LV gets dilated, and sometimes cardiac failure starts. So that is what the physiology is. And that's why we say that maybe the RVO might be the measurement of the systemic blood flow, because there is a contribution majority is by the systemic blood flow, and LVO, as we feel that there might be contributing to the systemic circulation, but it is predominantly influenced by the ductus, and that's why it is a measurement of the pulmonary blood flow rather than the systemic blood flow. So you might have a high LVO, and still you might have a steal. So that's why you need to measure the cardiac output, but also look at the steal, which Dr. Mohit will talk in more details. So that's how the PDA physiology in the nutshell. Now, the the effects of the PDA depend on, as we all know, depend on your QPQS ratio. So what is the ratio of pulmonary circulation to the systemic circulation? So normally they should be balanced, they shouldn't be steal. But in PDA, there is more circulation to the pulmonary and less circulation to the systemic. So your QPQS is affected. And that is why, because of that, you get systemic hypoperfusion and pulmonary flooding. So when you get systemic hypoperfusion, it affects predominantly our organ of concern is your brain. So it affects your cerebral blood flow. So it causes poor perfusion, IVH, reperfusion injury, etc. It affects the gut blood flow. So there's a ductal steal, NEC, feed intolerance, and then it affects your systemic blood flow, causing poor perfusion, metabolic acidosis, lactic acidosis. So QPQS mismatch causing systemic hypoperfusion and effect on the brain, gut, and systemic circulation. Then, because of this mismatch, there is a pulmonary flooding which is happening, and there is a increased pulmonary blood flow, which will cause increased oxygen requirement, ventilation support, and pulmonary hemorrhage, causing respiratory morbidity and mortality, and cardiac dilatation and CCF requirement and need of diuretics. These are the effect because of the continuous flooding of the lungs, and effect on the heart because of the over circulation from the lungs into the left side of the heart. And all these effects will be more pronounced with increase in the volume of shunt and duration of the shunt. And that is where most of the trials don't answer that how much is the shunt volume, and whether you should look at for how long these ductus remain open and the heart and the lung is exposed to this shunt volume for what period of time. And that is something we know we should try to judge. Now, I'm coming to end of my this thing, and we'll just briefly talk about some of the management principles, and we'll leave the drug choice and everything for Dr. Arvind to speak about, and ligation, Dr. Yogin, and other discussions. But when I want to know, I know the echo criteria, but are there any clinical criteria which I can look at? And as we know, most of the time the females do better in the premature in the neonatal ICU, because of there are a lot of benefits of being female, but unfortunately there are no benefits of PDA. So there is no sex difference observed in the observational triad. As you can see, there is a lot of other benefits are there in when you compare males versus females. There's a lot of disadvantage for the male sex, which is not there in the presence of PDA. So it doesn't matter if the preterm is male or female, but it does matter if there are other additional pathological contributions. So what are the endotypes, or what are the specific phenotype or the history parameters which one should be aware when you are approaching the ductus. So there are certain ductus which will give you trouble compared to there are certain ductus which will be innocent and which you can know from the history. So we know that prematurity is the biggest culprit. So we spoke about that, and more prematurity of the baby, the more problem it will cause. The sex, there's made no difference. Then what are the placental pathological conditions? As you can see, if you have chorioamnionitis, both clinical or histopathological, then you have an increased risk of PDA. So anything with that background, we should probably be more aggressive in addressing this PDA, because they tend to remain open and cause more complication. Hypertensive disorders of the pregnancy is not showing direct effect, but it has shown some effect in the management, which we can briefly talk about, but not as a PDA presentation. And also, importantly, any growth restriction. Generally, I mean generally the notion is that IUGR growth babies do behave differently, and some of the older IUGR babies also, the ductus may tend to remain open. However, if you look at the observational trials, it has shown to be at lower PDA risk if you are less than 10th percentile. So again, certain factors we need to be talking about. Twins also, the PDA might behave differently. How the twins will behave to the treatment also might difference. So there's additional factors do play a role. Now, just echo, Dr. Mohit will talk about, and I'll skip that what assessment you will do. But there are additional, if you don't have an echo, whether any other parameters which might help. So there are many parameters I looked at, almost like 10-15 parameters. None of them are very useful, except for maybe two of them, which I will highlight here, is plasma NTP-BNP. So N-terminal pro-BNP is a nitric peptide which is secreted with the dilatation of the right atrium. and that might be measured in plasma and urinary BNP. And more accurate is probably plasma. And there are a few studies published and talking about it. Even we had published our own data of 51 infants, and there are some cutoffs which can be identified, which will predict that this ductus will remain open. However, there's a lot of heterogeneity of the levels and timing of the ductus measurements. The reference rates are not standard. Plus, you have to do a blood measurement, and also expensive, not available in many places. That's why this has not picked up very well. But it could be an additional marker along with the echo to help you to predict that the ductus might remain open, and it could be a good marker for even doing studies related to the PDA. And now, I think this slide is very important, but we will have this slide because this will steal away all the discussion about management principles. So I will leave that approach, whether you need to do prophylaxis treatment or a pre-symptomatic echo-based or a early symptomatic based. And we can come back to this slide towards the end of the panel, and we can talk more detail about it. Now, just few things. Last 2 minutes more I will take, and I'll end my session. So just few things and broader approach about the PDA. So again, so if you find the PDA, again, no need to jump and start treatment straight away. There are some expectant and conservative management also can be done, such as to reduce the shunt volume to the lungs. We saw that PDA floods the lung. So can we do something to reduce that? So one of the simplest thing is increasing the PWP on the ventilated baby. So increase the positive pressure ventilation, allow some permissible hypercapnia. So accept higher CO2s. Don't overventilate this baby. So this baby the pH might be low because of the steel and acidosis. And then you tend to wash out the CO2 to correct the pH. So accept low pH, maybe 7.2, allow higher CO2, and because that will help for not only PDA but also for the lungs, right? You are not overventilating. And then care fluid management. Now, there was a knee-jerk approach in many centers that the moment PDA is there, okay, restrict fluid, go down by 20 mLs, go down by 20%, whatever. You have to be very careful with use of fluid restriction diuretics. So best approach, if you have an incubator, is to hide the humidity and then maybe keep the fluids restricted and don't go up, but you don't have to cut back. You have to give the fluids to maintain your electrolytes and your weight and everything. And obviously, many times you have to go to 180, 200 if you're in an open care for a very extreme premature babies, and that could probably the risk of opening the ductus. But you don't have to restrict to 100 or 120 immediately, because that is not the primary contributor for the PDA. Yeah, so no specific intervention aimed at PDA, lack of evidence for this strategy. So not doing anything probably is not also safe, because we saw what are the clinical effects, which we cannot ignore. So we cannot not do anything. That approach is probably still not very popular. So this is again restrictive versus fluid. We said, so there are studies looking at 145 versus 110, and there's no effect on the PDA dimensions or SVC flow, but it does not support use of fluid restriction with HSPDA in first week of life. And more so, if there is a ductal steal, you might make things worse, because if you are underhydrated along with the steal, your acidosis, renal ischemia might get worsen, or the gut ischemia might get worsen. So use of good humidification and cautious fluid management. Next is furosemide, benefit or harm. So in early days of life, no need of this thing. So PDA, furosemide only given late PDAs, only with evidence of cardiomegaly. Routine diuretics in the first week of life is probably not required. There are you are exposing side effects of the drug without much benefit on the PDA. Caffeine has shown to be beneficial for everything, long-term outcome, lungs, and also PDA. It's good. So all the preterms anyway, our interest is less than 30 weeks. So they anyway get caffeine. So caffeine is beneficial for PDA. So give it. And then which drugs to use. And there are different approach. So again, this medical part of the PDA management, I will leave it. These are different sort of physiological approach. We can come back to it in the management discussion. So I'll skip that, and one should be mindful of the side effect. So ibuprofen has better safety profile than indomethacin. Indomethacin has got a lot of effects on the platelet function, IVH raise, gut, platelets, etc. Ibuprofen is less sort of side effect, and paracetamol is even lesser. Now, just on the note of what we discussed, or the future direction, as we said, why we are not getting the evidence. This is a good side by Afif El-Fakash, published in one of his papers, and he talks about, all those things which we spoke, that in the future trials, not only the PDA diameter and LAO ratio, we should also look at shunt volume. We should measure the end organ injury like MCA, celiac, aortic, renal Dopplers, and then also look at the patient population. You should target the lower gestation babies only. All the babies who are risk at BPD, there are BPD scores predictors are available, sepsis predictors are available. So those who have risk of sepsis, chorioamnionitis, risk of BPD, antenatal hit, they have again antenatal choreo or IGR or placental issues, and then heart dysfunctions, and not just the diameter, but the more comprehensive treatment should be the selection criteria for the patient. And the timing of intervention is very important. Again, what should be the day 3, that again we will talk about it, but the treatment should be addressed to ensure closure versus maintaining patency. So we have to give adequate doses, a good drug of choice which is more effective, and ensure the drug delivery is correct, and avoid basically avoid over-treating. So there has to be a balance, and aim is to close the ductus. So you have to ensure the drug that ductus is closed. So many times only they receive treatment, but ductus doesn't get closed. So although they remain in the treatment arm, the comparison is still not same because the ductus is still remain open in both the groups. The comparison doesn't occur, and no open label treatment should be allowed. Probably, one has to be very strict, but this is something really hard to do it because clinicians are different, and that is the problem of PDA trials. But something one has to really, people have to come together and come up with this idea that okay, we will not allow any treatment and we'll just have the two approaches of closed versus open. And the outcome assessment not only always is death and the morbidity or neurodevelopmental outcome, but one should look at the CLD, neck, PVL, and then death. Those are also important because they indirectly contribute to the morbidity and mortality. So with that, I'll close my talk. So we went through the physiology, we went through the different approach, and the character. We have to look at the clinical criteria, the echo criteria. We will study now soon, shortly. The biomarkers are there for help. Timing of treatment, something needs to be discussed. What dosing needs to be discussed. Device closure probably coming in next few types, and we have to identify probably. I think we need to, for a PDA is one topic where probably we need to do like maybe a precision medicine or an individualized approach, that we need to find out the background of the baby, the gestation of the baby, and then what are the risk factors, then look at the clinical hemodynamic criteria and maybe support of the biomarkers, and then come up to the conclusion whether you treat this baby or not, rather than just doing the evidence-based approach. So with that, I'll stop. Thank you. Question, but probably I've run over time, so we'll take the questions at the end. Thank you.
No, it's fine. Thanks a lot, Dr. Kiran. There are a few questions we can take, and I think so. There will be a kind of Dr. Arvind's lecture needs to be adjusted, so that we will see. So there are 4 or 5 questions related to your talk. We can take that. So one of the question is, can we give 1 dose of ibuprofen at birth for all preterm babies like vitamin K?
Good thought.
Very interesting question.
Very interesting question. And I think I will leave this question in this thing, because see, again, so you are believing that all PDAs are problems. In one of the slides, I said some PDAs may not be the problem. So treating blindly is like shooting in the dark. So if you are treating PDA without the echo, and without knowing if there is a ductal dependent circulation, or there is maybe a PPHN going on, closing that ductus might be disastrous. Plus, you are exposing all the babies with ibuprofen side effects. So your incidence of NEC might go up, or feed intolerance might go up. So this is something not very much still advocated. I know there are centers who are now starting with paracetamol because we perceive it is a less side effect as a prophylactic. But I think treating blindly is something might be disastrous, because we have seen sometime babies who don't transition, they get flipped into pulmonary hypertension, and closing these ductus medically can make things worse. The RV can actually fail, and you might just lose the baby. You try to close the ductus, but you lose the baby with cardiac failure. So I have reservations about prophylactic approach, but we will discuss this in the panel again. So something we would not probably recommend.
So another question by Dr. Shiripad only. Can we keep all babies in oxygen hood for 5 to 10 minutes as birth? Will it help to close the PDA?
Absolutely not. First of all, hood should be out of the NICU. I have thrown away hood, oxygen hood out at all. Even when Vadia had stopped using hood. Hood is a very uncontrolled oxygen. Pure oxygen doesn't help. Only that's not the only way. Obviously, prostaglandins play a role, but yeah, inadvertent oxygen therapy has more side effects. So it's always the risk and benefit what we look at. So giving excessive oxygen will cause ROP, other oxygen-related radical free injury. Baby might get apneic and get intubated, and that might even make the PDA worse. So again, conservative approach, CPAP with probably in air or minimal oxygen is a good way to go than using oxygen for ductal closure. Yeah.
So there are a lot of questions are there. I will take few more. How confident we can brand them as silent, innocent bystander in the scenario?
Right. Good question. So again, more information. So it's like, see, you can shoot in the dark or you can shoot at the target. If you have a target in front, probably your chance of hitting the target are better. So treating prophylactically, treating just clinically, you're like shooting in the dark. Doing more like echo parameters and knowing the PDA, sometime following the PDA every day will give you more information, and then you're probably more closer to the truth. Again, you can ventilate the babies without ABGs, right? Many times with cost issue or not availability, we still can ventilate. But if you want to do a precise ventilation, we would like to know what's happening with the CO2 or the pH and PO2. So it's like that. So more information you have, probably more wiser decision you will take.
Okay. So this question is somewhat, Dr. Steve, what's the mechanism of humidification in preterm PDA? Did you
Yes, so
mention
mechanism, yeah. So what I mentioned is, so what happens? So again, traditionally we know if we give too much fluids in the first 2-3 days, yeah, the closing ductus also might get open. So there's always this concern about that, and the contrary to that people do restrict the PDA fluids for all the babies where PDA is diagnosed. But if you babies in the open warmer, babies will tend to lose fluids, tend to lose a lot of sorts of insensible losses more, and these babies tend to get high sodiums and drop in the urine output. So you have to use the higher fluids, and sometimes, as I said, you have to go 160, 180, even 200 because they're losing a weight lot. So when you use humidification or warmers, you reduce their insensible losses, so you can actually go up slowly on the fluid. So you can go only by 10 or 20 mLs when you use humidification. You can remain on 100 and 120 ml and still maintain the electrolyte balance very well. That's why cautious fluid management is important in PDA. So if you have ability humidification, then it's good. Many people actually even cover the warmer with the transparent sheet, and people have even tried putting some humidity inside that, but that's kind of a not ideal way. But idea is again to reduce the warmer, to reduce the fluctuations and insensible losses, which might help.
So there are other. I will take this last question and then we will switch over. We will start with the other next talk. So you have to be very careful with this. Around 400 plus people are watching you. This is by Dr. Jalil. Why don't we have national common treatment guidelines for PDA?
Okay. So I think, I think should we take this question at the end of panel, because we have all elite speakers in the panel. So please wait to answer. So there are guidelines, and many of us are part of the clinical practice guideline group as well. And but yes, you're right. There has to be one approach, national approach to management of the PDA. And maybe we'll just answer this question at the end, whether we should come up with such a standard this thing. But so there are guidelines, and in fact we had also published in one of the books also the approach to PDA. We will talk about this in the panel or end of the panel.
Okay. So I will stop taking questions. There are almost more than 40 questions.
Wow.
So it will be not possible to take all the questions.
Yeah, we'll
So
try
I've taken
to.
few.
Yeah, I'll go through it. Like, we will just make a summary of all the questions at the end.
Yeah.
Mm.
Okay.
Okay.
Sure. Thank you.
Thank you.
So now the next session we will start with as Dr. Kiran has already mentioned regarding the pathophysiology or anatomy, the issues that the PDA create. Now, as there were few lines within inverted comma by him that I would not like to treat the PDA before getting an echo done. This was because he wanted to ensure that it is not a duct dependent lesion, neither a left-sided or a right-sided duct dependent lesion. Otherwise, if you close that PDA, the baby may die. Then now he mentioned few of the studies, Benedict study and all those studies he mentioned. There they have used an approach what we call as PDA monitoring. So what we do in PDA monitoring is we have been seeing the indices, various parameters in the echo to label it as a HSPDA, and there are quite a few publications on that. So we will just see in this next half an hour or so. First, we will see what are those parameters. See, in actually, when we go with the theoretical, there are 21 parameters. But normally in day-to-day life, we don't do those 21 parameters. So what I will be mentioning in the presentations will be around 11 parameters. And we look for those 11 parameters, and then we classify that is a small PDA, medium PDA, or a large PDA. That is whether this PDA is hemodynamically significant or not. So, and then after that lecture, there will be a live demo of all those indices that I will be talking in the presentation. I hope you can see my slides. Okay. So this is just to give you a reminder that our 5th batch will be starting from July 2024. So those who are interested can scan this QR code or message on this number. So this is what like PDA we will be discussing. So let's start with one scenario. So this scenario will set the ball rolling for our PDA indices. And I know those who are participating as an audience, they will not be able to, speak or directly messages we cannot get, but we can get through those messages. So in the dashboard, I can go through that. So we will then see what all responses you have registered. So this is a preterm baby, 28 weeks, weighing around 1 kg, baby boy, born to 32 years old, gravida 2, para 1 mother. The antenatal course is unremarkable. And steroid last dose 1 day prior to the delivery was given. There is no premature rupture of membranes. Antenatal ultrasounds are normal. Everything in labor is being fine, born by normal delivery. There was increased work of breathing. These are the ventilatory settings. 14 PIP, PEEP of 5, FiO2 was started on 35%, decreased down to 21% within 30 minutes. And within 2 days was extubated to CPAP, started on caffeine, and on day 4 started having increased oxygen requirement on CPAP. By that time, the baby was on feeds of 2 cc every 2 hourly, started having minimal aspirates. On examination, vitals were stable, chest was clear, there was a murmur, heard 3/4 grade. Pulses, they were palpable, all the 4 limbs, they were equal, they were not bounding. This is the heart rate 168, respiratory rate 62, blood pressure of 45 systolic, 22 diastolic, mean of 30. If there is a mean of 30 for 28 weeker, from the blood pressure point of common thing, what we believe is your mean blood pressures is equal to the gestation, while there is a lot of controversies behind it. But even then, we just take, okay, that is fine. We take it as normal. Abdomen is soft, bowel sounds are normal. So what is the problem with the infant now? Pneumothorax, deterioration of the RDS, PDA, or anything. So you can even type the color green, blue, white, or pink. I will give you few seconds, 10 seconds to register your response, and then we will see that response. Okay. So now, see, even though we have been talking about the PDA, okay, about the echoes, but the basic things first. So in this baby who is on positive pressure ventilation, my response will be, the problem will be that I would like to rule out dope. Okay, so dope is something that is more common, and we have to rule out those things if the baby is on positive pressure ventilation. So that is whether if the baby is intubated, you have to rule out the displacement of the tube, pneumothorax, so you have to rule out the pneumothorax in these babies. So rule out pneumothorax, rule out any secretions, and then go ahead to look for other causes. So initial investigation, what I will ask, I will rule out the sepsis, which is very common, especially in India. Okay, and then X-ray chest to rule out the pneumothorax, or you are trained in point of care ultrasound, so lung ultrasound, you can use that technique, or cold light technique. So this was the X-ray, and as you can see in the X-ray, the lung spaces are good, bilateral haziness is there is no pneumothorax, and the sepsis screen was done, which was normal. So the provisional cause of deterioration, now you can either, it can be IVH, because that is a high time for these preterm babies to get IVH, or it can be the PDA. Okay, so why I would say this PDA? Because if you see this clinical parameters, you can see a wide pulse pressure. Okay, murmur is not very specific for any of the congenital heart disease or the PDA, but your blood pressure is indicating that there is a wide pulse pressure. So if that is a PDA, clinically we have detected, so what will be my plan of action? So that is a question that will be discussed in the panel by one of the very senior neonatologists and couple of young neonatologists who have been doing hemodynamics and following hemodynamics. And let's see how the outcomes will be. So we will talk about the echo in this. So if the echo is being done, the PDA is 1.8 millimeters, shunting left to right, and the heart is structurally normal. That means that there is no duct-dependent cardiac lesion in there. So again, I would like to ask people, if this information is good enough for you to treat the PDA, that means just the size of the PDA. You can write yes and no in your responses, and then we can check your responses, that what response you have given. So all the investigations are normal, and we treat this PDA just on the basis of PDA size? No, because there are other parameters, and that we need to know. The first thing we need to know is whether the PDA is there or not. Only then you will treat, isn't it? So first look for the PDA. Then the next question is whether this PDA is hemodynamically significant or not on the echo. And then the question will arise, I need to treat this PDA? If yes, then with what? So those drugs and all those things, the controversies that we will see in the panel. And if we are treating this PDA, or if we are not treating this PDA, then how closely I want to monitor this PDA, as I was discussing about PDA monitoring. This thing has been talked about regarding the anatomy and all. Dr. Kiran has talked about. So this is just an animation to show you that this is MPA. See, in the ductal view, whenever we do the ductal view, there are two major components that we should include. One is your pulmonary artery, other is your descending aorta. These are the two prerequisites that should be there in the ductal view. So this is your MPA, RPA, LPA, and this is your descending aorta. So your PDA starts from the descending aorta, it goes up and join the main pulmonary artery towards the LPA side. Okay, so here is your probe. So the blood flow in the pulmonary artery is flowing away from the probe downwards. That's why it is blue. The blood flow in the descending aorta is away from the probe downwards. That's why it is blue. But if your duct is shunting left to right, that means the blood is going from descending aorta towards the pulmonary artery. So this blood is shunting towards the probe. So that's why it is red. If the pulmonary pressures are high, then in that case, the blood will flow from pulmonary artery towards the descending aorta. So the direction of the blood flow in that case would be this. And that will be away from the probe. So it will be blue. So it will be blue color. So left to right shunting is red in color, and right to left shunting through the PDA is blue in color. This is just for, you need to remember that. This thing has been talked about. I won't go in detail for this. So we will directly come to the functional echoes. So whenever we even talk about the functional echoes, it is always like in clinical presentation, because of PDA, the the echo parameters, with all those parameters, when we label that it is HSPD or not, are also based on two things: pulmonary overcirculation and systemic hyperperfusion. And this is because of the shunting of the blood from descending aorta to the pulmonary arteries, that is from left to right. Because of this left to right shunting, there is pulmonary overcirculation and systemic hyperperfusion. So to say whether the PDA is HSPDA, hemodynamically significant PDA, one, we need to know the ductus is patent. Then we check for the flow patterns in the ductus. And then we look for the parameters that tell us that there is organ or systemic hypoperfusion. And then there are parameters which tell us that there is pulmonary overcirculation, and hence it will cause the left-sided volume overload. So now look at what are the pulmonary overcirculation parameters that tell us that there is a pulmonary overcirculation in the functional echo. Few months back, we conducted a whole series of point of care ultrasound that included functional echo, head ultrasound, and lung ultrasound. There we discussed regarding the views, neonatal echo views. So I won't be going in detail of these views because that we have already discussed in one of the CMEs and symposium. But there I did talk, and every time I talk that you have to follow one sequence. I always start from apical 4-chamber views in the newborn and end up with the subcostal views, because subcostal views are disturbing and they disturb the baby and irritate the baby. So when we put on the apical, we start with the apical 4-chamber view. And the first thing we would see is LALV is dilated. Like the baby we discussed, 2-day-old baby, 1 kg, 28 weeker. If I do an echo on this baby, the image that I will have in my mind is that their right-sided pressures are physiologically high. Therefore, your RARV, the right-sided pressures are high. So RARV will be predominant chambers. But a 2 days old baby, 1 kg, if you see the LALV is dilated, is a predominant chamber, then that means that there is a volume overload. So that indirectly tells me that there is something which is causing volume overload of the left side. And the most common thing is your left to right shunting from the hemodynamically significant PDA. So first thing I would see in a apical 4-chamber is LALV is dilated. Next thing, I will put a color on the mitral valve and look for mitral regurgitation, MR. And then do an inflow from the mitral valve with a pulse wave Doppler and check for E by A ratio. What is E by A ratio? I will discuss. And then we do IVRT, isovolumetric relaxation time. We calculate the left ventricle volume, LVO. So that is left ventricle index, how much volume has been passed out. And then in parasternal long axis, we do L by A ratio. And we look for the pulmonary artery Dopplers and look what is the diastolic disturbance, end diastolic disturbance velocity. More is the flow from the duct in the pulmonary artery, more will be the diastolic disturbance in the pulmonary artery. Sorry. So this is a apical four-chamber view. You can see where I am keeping the probe. I'm keeping the probe just below the apex. Pointer is pointing at 2 to 3 o'clock position. This is an upright view. This is a probe orientation marker. So this is your LA, LV, RA, RV, interventricular septum, intraatrial septum. So in this, can you see this apical four-chamber view of that baby we discussed? Very clearly you can see the LA-LV here is much bigger and dilated as compared to RA-RV here. So your LA-LV is dilated. So that is the first thing you will notice in hemodynamically significant PDA. The next thing is calculate the MR. See, here is your probe. The blood that flows from LA to LV will be red because it is towards the probe. Mitral regurgitation will be the blood flow through the mitral valve from LV to LA will be blue in color. So this is your MR jet. So I put a continuous wave Doppler here and calculate the MR jet. Then we go to, this is apical 5-chamber. So the probe is same below the apical window, at the apical window below the nipple. The probe pointer, you can rotate it from 2 to 3 o'clock and sweep the probe upwards interiorly. So there you will open up the 5th chamber. What is it? Is aorta, LVOT. So this is your LA, LV, RA, RV, and this is your aorta, and this is your aortic valve. So we keep pulse wave Doppler here and calculate the VTI of the aortic flow so that we can calculate the LVO, left ventricle output. Okay. So that was apical 5-chamber. So in apical 4-chamber, we discussed LA-LV dilated, did MR. So there is this inflow here. There is a blood flowing from LA to LV. In this inflow, just below the mitral valve, we'll put a pulse wave Doppler and we calculate the E and A ratio. So these are basically, see, on this x-axis is always your time and this y-axis is always the tracing of velocity. So these are two peaks of the inflow of the blood coming from LA to LV. The first E wave is basically the diastolic function of left ventricle. That is, because of diastole, when the LV dilates, the blood flow from LA to LV. So this is the velocity of that inflow, that by virtue of diastole, when your mitral valve opens and the blood from left atrium gush into LV. So this is that flow, velocity of that flow. Then the next sequence in the next step in the cardiac cycle is there is systolic phase. So atria goes into systole and the blood which is being left in the atria because of the atrial systole is pushed from LA to LV, and this A wave is the second wave because of that velocity, because of that flow. In term babies, E and A ratio, E by A ratio is 1, that is normal. In preterm, your LV is, there is diastolic dysfunction in your preterms, especially the babies who are less than 1 kg. So because of that diastolic dysfunction, your E is always smaller than A. So the normal value of E by A ratio in preterm is 0.6 to 0.8. So if there is a volume overload in the preterm babies, So because of the volume, as soon as your mitral valve open, already there is a lot of blood collected in LA. So that blood will be rushed into the LV, and hence the peak velocity of A will go up. So your EA ratio, which is normally less than 0.85 in the preterm babies, is 1 because of the high velocity of the high volume, because of the high volume in the blood that is gushing from left atrium to left ventricle. And hence your E by A ratio becomes 1. So that is pseudo normalization of the E ratio in the preterms. So in HSPDA, because of the volume overload of the left side, your E ratio, which is normally less than 0.85, is 1 in the preterm. So E by A ratio in preterm babies 1 means there is volume overload, and hence it can be because of the big duct. This is normal. So if you have a volume overload, okay, more than 0.85, or we normally take it 1. Anything which is 1 and above is HSPDA. Okay. So then, as I was telling you, this is the apical 5 chamber. In this, we put the pulse wave Doppler in here, and we calculate this. This is the tracing of the aorta. So this is the VTI. So we calculate the LVO by this formula, pi r square times heart rate. You have to register the heart rate before starting an echo, because otherwise the baby will become tachycardic. And the VTI which you have calculated and weighed in kgs. So this R is the radius of the aorta. So after this, here you keep the pulse wave Doppler and you calculate the VTI. Then you go to, you trace this aortic Dopplers, and machine will give you the VTI, that is the velocity time integral. Then you go to the parasternal long axis view, where the pointer is pointing towards right shoulder at 11 o'clock at the nipple line. Probe orientation marker is up here. You get this parasternal long axis view in which the heart is being cut longitudinally. This is your anterior wall of RV cavity, interventricular septum, LV, mitral valve, LA, and this is aorta. So I will do the calculate the diameter of aorta in this view. The prerequisites are that this aorta should be within the center, horizontal, and then when you freeze it, it should be calculated in the frame when these aortic valves are open, and from inner edge of aorta to inner edge at the joint of aortic valves. So you get a diameter, and then you halve those diameter to make it a radius and calculate with this formula. The normal value is 130 to 300 ml per kg per minute. So if it is less than 300, it is normal. It is 300 to 400 is moderately large duct, and more than 400 ml per kg per minute is large duct, the HSPDA. Then in the same view, we do the LA by AO ratio, LA-AO ratio. That we do in M mode. So you have to have a same parasternal long axis view in which the cursor line will be passing through aorta and left atrium at the level of aortic valve. You should capture the aortic valves moving in this cursor line and then press M mode. When you press M mode, that is a motion mode, it will trace the tracing and movement of aorta and left atrium. Where these aortic valves are open, before that you take this diameter, that is aorta, and take the diameter of left atrium in diastole, where it is largest, like this. This is systole and this is diastole. You should take it in the diastolic phase. Then the machine will give you the L by AO ratio. So LA ratios normal value is 1 to 1.5. If it is 1.5 to 2, that means moderately large duct, and more than 2 is severely large duct or severely hemodynamically significant duct. Then in the same parasternal long axis view, if we sweep upwards, we get into the pulmonary artery view. So this is your pulmonary artery. So we put our pulse wave Doppler here in the middle of this pulmonary artery, just below the around 1 centimeters below the pulmonary valve, and do the Dopplers. When we do the Dopplers, this is the normal pulmonary artery flow. This is systolic flow, and you will have some diastolic flow here in between the two systolic peaks. But if there is a PDA, there is a left to right shunting. So you will have a lot of disturbance because of that left to right shunted flow in the pulmonary artery. So we calculate this end diastolic velocity of this diastolic disturbance, that flow we get. If that is less than 30 centimeters per second, it is a small PDA. If that diastolic, more will be the blood flow from left to right, more will be the disturbance. And hence, if the velocity is 30 to 50 centimeters per second, that shows the moderate duct. And that disturbance, if it is more than 50 centimeters per second, that shows that there is a large duct. So we do the pulmonary artery Dopplers and look for, so this is normal. Here you can see if this end diastolic velocity disturbance is less than 30 centimeters per second, it is mild, small duct. 30 to 50 centimeters per second, it is a moderately large duct. And more than 50 centimeters per second, it shows it is a large duct. So these are the parameters that we check to look for pulmonary overcirculation indices. Was mild, moderate, severe, size, large, mild or small duct, moderately large duct, severely large duct. LA-LV is dilated, this one. MR less than 2 plus, 3 plus is moderate, more plus is severe. E by A ratio, 1 mild, 1 to 1.5 moderate, more than 1.5 large. IVRT is isovolumetric relaxation time. I skipped because it becomes, it's a kind of advanced parameter that we do. Normal values of IVRT is 40 to 50 milliseconds. In moderately large duct, it is 20 to 40 milliseconds. In severely large duct, it is less than 20 milliseconds. So smaller is your IVRT. It means larger is the volume overload. And that large volume overload is because of the large duct. Then we calculate the left ventricle output. I told less than 300 is normal. 300 to 400 is moderate. And more than 400 ml per kg per minute is large duct. LA ratio that we took in parasternal long axis, 1 to 1.5 is normal. So around 1.2 to 1.5 is mild. 1.5 to 2 is moderate, and more than 2 is severe. Then we do the pulmonary artery Dopplers, and we look for the diastolic, that diastolic disturbance flow is there. We look for the end diastolic velocity. If it is less than 30 centimeters per second, it is mild. 30 to 50 is moderate. More than 50 is severe. So those were the things, that 7 parameters that we discussed, that tell us that there is a pulmonary overcirculation. Now we will go to the high parasternal views. So that is a duct view. So ductal view, we will look for PDA size, and we will do the Dopplers of the PDA. So ductal view is a high parasternal view where the pointer is pointing at 12 to 1 o'clock position, and the probe is being kept in the left subclavicular area, here. Okay. Or some people they do it in the parasternal short axis view also. It's because it's a modified short axis view by angulating the probe upwards. But I would always like, the easiest way is by doing it in the left subclavicular area, left side of the clavicle. You see the pointer is up here. So pointer is here, and here, therefore, this is your pulmonary artery, and this is a descending aorta. So these are the two things we need to capture in the ductal view. Here you can see, I told you the blood flowing in the pulmonary artery and descending aorta is away from the probe, therefore it is blue. If the duct would have been there and shunting left to right. The blood is then flowing from aorta towards pulmonary artery, will be towards the probe is red. See this. So this is a PDA in which the blood is flowing from descending aorta towards the pulmonary artery, is red in color. It's pure left to right shunting. So when I would like to take, so this is a descending aorta, pulmonary artery, PDA is shunting left to right. Always try to measure the size of the duct in the 2D. If the duct is very small and it's not possible to measure the size of the duct in 2D, then only you go for the color. But color is not very specific and is always overestimation. In here, we always tend to measure the size of the PDA when the PDA enters the pulmonary artery. So this is your pulmonary artery, MPA, RPA, LPA. And here is the descending aorta. So this is your duct which is entering into pulmonary artery. So I would like to measure the size of the duct here where it enters the pulmonary artery, because that is a place where that is a section which is the most constricted part of the PDA in most of the cases. So we always measure the size of the PDA when the PDA enters the pulmonary artery. So here it is very specifically seen that here is the PDA when it is entering the pulmonary artery. In color, it is very difficult to assess. So how we do this? Where it is most constricted, we take that size. But then you have to see whether it is that part is within the pulmonary artery, that is a flow of the duct within the pulmonary artery, or it is just at the entrance of the pulmonary artery. And when I would like to do the Dopplers, I would like to do in the canal of the PDA, not here. Here, this is the flow of the PDA within the pulmonary artery. This is towards the aortic end. So this is the canal of the duct itself. So I would like to put my pulse wave Doppler here and do the Dopplers of the PDA. Okay. So this is, you see what we call sometimes this view as 3-leg view. MPA, RPA, LPA, and this is the duct. And here it is entering the pulmonary artery. I would like to take the size here. So as per the size, small, less than 1.5 millimeters, moderately large or medium size 1.5 to 3 millimeters, more than 3 millimeters is large. Then we do the Dopplers, and I told we always tend to do Dopplers in the canal body of the PDA, not its flow in the pulmonary artery and not even towards the aortic end. So when we do this, we look for the shape. Now it is a pulsatile flow. Here the diastolic flow is much above the baseline, and here it is very high. So shape-wise, this is a pulsatile flow. So that shows as a hemodynamically significant PDA. This is an intermediate pattern, or what we call as the restrictive flow. And here it is a closing pattern. The best way to know that is you look for the peak velocity, peak systolic velocity. If the peak velocity is less than 1.5 meters per second, it means the PDA is large. 1.5 to 2 meters per second, it is a moderately large PDA. In the peak velocity more than 2 meters per second, it shows there is a closing or a very small duct. Here you can see in this example, the peak velocity is 1.5 meters per second. And the pattern is also pulsatile. Here, the peak velocity is around 3.7 meters per second. And it is a closing pattern. So just by seeing the pattern and taking the peak velocity, you can judge whether the PDA is hemodynamically significant or it is closing PDA. Okay, and it has to be pure left to right shunting. In left to right shunting means your left-sided pressures are higher in systolic and diastolic both phases, and hence you will see red color, and all the flow patterns which are been recorded are above the baseline. Then comes so we discussed regarding pulmonary overcirculation. In that we discussed 7 parameters. Then we discussed the PDA is patent. We discussed regarding the size of the PDA and the Dopplers of the PDA. Now we will see whether because of this PDA left to right shunting, there is any systemic hypoperfusion that is taking place. So we do the Dopplers of descending aorta and Dopplers of celiac and SMA. Okay, so we do, this is the aortic view, arch of aorta. In the descending aorta, that is after the 3rd branch of aorta, we put a pulse wave Doppler. This is the normal tracing. These are the two systolic peaks, and in between there is a diastolic flow. There has to be some diastolic flow in the normal conditions, because if there is a PDA, there will be a ductal steal, and hence the diastolic flow will become absent. So if there is an absent diastolic flow, it means there is moderately large duct. And if it becomes reverse, the diastolic flow becomes reverse, then the ductal steal is severe. So that means there is a large PDA. And then we do the subcostal views, in which we go for abdominal aorta. This is abdominal aorta, this is spine. And there are two branches, celiac and SMA. We put a color on that. We do the Dopplers of celiac and SMA. Okay, if this is normal, there has to be positive flow in systole and diastole. This is normal. If there is a moderate ductal steal, you will have an absent diastolic flow. And if there is a severe diastolic steal, then you will have a negative diastolic flow. So a systole diastolic flow positive means normal, moderately large duct, absent diastolic flow, severely large duct with HSPDA, you will have a reverse diastolic flow. So these are the publications in which the grading of the PDA eco-wise and clinical-wise has been published in 2007 in Archive of Diseases of Childhood. And here you can remember it, like this is the PDA size. I have discussed 7 parameters, and these are the parameters above that. That is, one is PDA size, peak velocity of the ductal Dopplers, more than 2, 1.5 to 2, and less than 1.5. And your celiac and SMA, descending aorta Dopplers, normal flow in systole and diastole, absent diastolic flow, reverse diastolic flow. So in total, there are 11 parameters that we have discussed. And then according to those parameters, we will grade. Out of 11, the category in which 70% of total, like 7 out of 11 parameters, when they fall in one category, mild, moderate, and severe, so we label the duct as mild. If 7 or more parameters, they fall in the category of mild. 7 or 4 more parameters fall in category of moderate, we label the duct as a moderate. So it is not based only on single parameter, that is just on the basis of size. It will include a lot of other parameters. There are in total 21 parameters, but I have discussed only 11. And out of 11, 7 or more, when they fall in the category of mild, we will label the duct as mild. Fall in the category of moderate, we will label the duct as moderate. Fall in the category of severe, we will label the duct as severe. So HSPDA always falls in the category of moderate to severe. Mild to moderate, it will be mostly non-hemodynamically significant PDA. Moderate to severe and severe PDAs are the HSPDAs. So thank you very much. So again, if you want to join as a hybrid or online, pure online 6 months course, you can either, I've already given you the number, or you can mail on this email, nfecho2505@gmail.com. So I will look for the questions, if there are any questions, and we'll try to answer that. And then after that, we will go for live demo of the various parameters that we have already discussed. Okay. Okay, so there is a question that someone wants to know about the PDA Dopplers. So I will repeat that. Yeah. So yes. So I asked you the questions. Yes. So people have rightly said that they will not treat only on the basis of size. They will do it as per the other parameters. Echo parameter, LA ratios. Yes. Yes. Great. Yes. No. So they are not just treating. So then few people have answered for the pneumothorax also, and some told that to treat PDA, but the answer was to rule out dope. Yes, and there was a very nice comment by Dr. Faryal that we should look for the systolic blood pressure rather than the mean blood pressure. And it is very appropriate when you are treating any shock type of conditions in an HSPDA. So target your systolic blood pressures and not the mean blood pressures. And most of the people have answered pink, that was the PDA, but some of you have answered the pneumothorax. Okay, so there is an interesting question. Could we give fentanyl to prevent IVH associated with PDA? So see, it is because of the reperfusion injury. So even if you give fentanyl, you will not be able to prevent the reperfusion injury, because there are a lot of mechanisms that goes on, because there is inherent LV dysfunction. LV is weak, and initially because of the sudden exposure of LV to high SVR, and then the remodeling of the LV and reperfusion injury causes your IVH. So then it will not help you at all. If you restrict even the activity of the baby. So there are other questions, but time has already overshooted. For descending aorta Dopplers for systemic steel, so we put the pulse wave Doppler in the, I will just show you once, and then okay, there will be Dr. Kamal, are you there?
Yes, sir. I'm ready.
Yeah. So almost 500 people are watching, 478. So 2 questions have come. So I would request you, if you, while showing your parameters, you just show them where to keep the pointer at the descending aorta for descending aorta Dopplers. And then
Fine, sir.
for the ductal Dopplers, so ductal Dopplers, you will show, if the duct is not there, when we do the Dopplers of the duct in the body, the peak velocity we measure, and the peak velocity is more than 2 meters per second, it means the duct is small. 1.5 to 2 meters per second is moderate. Less than 1.5 meter is, that means the duct is large. Because of the laminar flow, the peak velocity will be low. So over to you. And then I would request everyone to pin the video of Dr. Kamal Arora, so that his video remains within the center of your screen. Or I would request the tech team to please pin his video, if you can, please. Thank you very much. Over to you, Dr. Kamal.
Yes, sir. Okay, without wasting time, sir, I'll jump onto directly to the indices which you have explained. Okay. So we are doing with the echo of this baby to look for the period indices, and we will be using this probe. This is thumbprint probe, and the frequency of this is 4 to 8 megahertz. So the first parameter which sir has told you is the 4-chamber view. So the pointer is, you can just point over here. So the pointer is pointing between 2 to 3 o'clock position. Yeah. It is between 2 to 3 o'clock position, not show over there. So I think you can see this. This is the left side, left ventricle. This is the left atrium.
Kamal, upright kar do na. Upright I have shown.
Okay, okay, sir. This is okay, sir? So we can see this is the left ventricle. You can see left ventricle is enlarged. So the size of this left ventricle is big as compared to the right. And this and the left atrium and the right atrium you can see. So left atrium is slightly bigger than the right atrium. As by the physiology, this baby is 1.1 kg. So we expect in the few initial days that the right side of the heart should be enlarged as compared to the left. But in this baby, we can see the left is enlarged. I don't know. I have not done this. This baby has a duct or not. But we can see that this side is enlarged as compared to the left side. So we have the first parameter, what Sir has told, Dr. Mohit Sani has told, LA and LV are enlarged. So what is the next parameter is? We have to go for the, see for the MR. So if I put a color over here, so I want to be in the 4-chamber view rather than the 5-chamber view. So this is, so we have MR. Let's see if it is there or not. No, there is minimal MR. So what we feel it is like 1+. I'll do it again. There may be mild MR. Yeah, mild MR. So like a 1+ MR. So my first thing which we did was the LA-LB dilated, MR 1+. Fine. So what do we do with the, and the third parameter is what we are seeing now is the pulmonary over circulation parameters. I'm just doing what Sir has just not taught you. So go in the 5-chamber view. That's okay. That's okay. That's okay. You should just. 5-chamber. Sorry. This we are showing now the. We have done with the LALV size. Now the mitral valve, mitral regurgitation. Then the EA ratio. So EA ratio, we have to put the Doppler just below the mitral valve. Just below the mitral valve. Just I'm getting an EA ratio, but I want to be more better than this one actually. So I'm shifting to the this one.
Yes, you can, because inverted is more aligned. So
Yeah,
if you
more-
are used to inverted, so you can anyone can shift to inverted images if you feel like it is you are more comfortable with that. Yeah, sure.
Yeah. So I'm getting a EA value here. So go to the calipers. Sorry, the calculations. Select the mitral valve. Select the mitral valve. Then select the E wave. So this is the E wave. So it is calculating for me as 68.9 centimeter per second. So save this value. Go to the A wave. So this is the A wave. So this is 68.9 and A is 56.3. So EA ratio is coming out to be 1.2. E is bigger, no? So E is bigger. So 68.9 divided by 56.3. So this machine doesn't give me the direct calculation as some GA, the GE machine gives. We have to calculate it. This is E and A. You can see this A, E is bigger than the A. And what sir has told you is E represents the atrial diastole. Because of the over circulation, it opens up early. The mitral valve opens up early, and you get a big E wave. And A is the atrial systole. That's the end of the atrial ventricle filling. So when the ventricle is filled, the atrial contracts are last, and after that the mitral valve closes. So you get an EA wave. So normally in the what again Dr. Mohit had told you in the last lecture, that in a preterm baby, the E and A ratio is EA ratio is less than 1. And in a preterm baby, if it comes out to be more than 1, then it is called a pseudo normalization, because in a term baby it reaches almost 1, and after that, after 1 month, it would be like 1.1, 1.2. So you are actually getting a pseudo normalization of the EA ratio. So here the EA ratio is 1.2. Okay, now you are clear with the EA. Going on to the 5-chamber view. So this is all we see in the 4-chamber view. We saw the LA and LV size was increased. There was mitral regurgitation, which was 1 plus. EA ratio, which is 1.2. E wave is bigger than the A wave, and pseudo normalization has happened. Then we go into the 5-chamber view. 5-chamber view, we see we just tilt downwards. So this is the left ventricle, this is left atrium, and this is the outflow tract of the atria. So let me see if I am aligned in this view only. Otherwise, I'll change the view to the upside down. So where I have to put the cursor to calculate the IVRT? I have to put between the just the baby is actually very. I have to change to. So where the red flow and the blue flow are together, I have to see that point, which means the red flow is what the atria is, the left atrium, the blood is coming to the left ventricle, and the blue flow is where the aortic outflow tract is there. So I am trying to find out that place. So it will be somewhere here, this place. So it will be somewhere here. This. So red is coming over here, blue is going from out from this tract. So I'll put the cursor somewhere here. Okay, let me do that. Okay, so this is the EA wave. This is where the outflow has ended, and with this is where the inflow starts. So, okay. So this is where the inflow has started, and this is where the outflow has finished. So let me calculate the IVRT. So just a minute. Just a minute. I'll do it. Yeah, better. So now this view is better. So I'm trying to help you. The best place is this one. Okay. So it is coming out to be nearly 50 to 55, which is coming out to be normal for me. Yeah. So it is coming to exactly 50 here. Around 45 to 50 is the value which I am getting with the other side.
Yeah, that was the normal. So normal value is 40 to 60. If
Yes,
it's
sir.
in between 20 to 40 is moderately large duct, and less than 20 is very large duct. So it is very nicely seen what Dr. Kamali is being shown.
Yeah, I'm trying to make it very sure, sir, so that I'm doing in the other view also. Because this baby, when we did around 2 days back, it was coming out to be around 40 to 45. So it means I'm trying to get the best place where I can do the IVRT. That was the best one, sir. That was a better one. Yeah. So it is coming out to around 50 to 55. Okay. So then we have the next parameter is the left ventricular outflow tract. Volume, sorry. Yeah. So we want to calculate left ventricular outflow volume. What LVO is now. So I'm in the 5 chamber view. So for the formula for the left ventricular volume is pi r square, where r is the radius of the aorta, and then we should know the velocity and then the heart rate. The heart rate of this baby is 148 when we started. So where do we put the cursor is just beyond the aortic valve. I'm trying to figure out that place just beyond the aortic valve. So yeah. So now we are calculating the VTI. So calculations. Aortic valve, VTI. So for the VTI, we need to trace the whole negative tracing. This straight. So the VTI is coming out to be 10.9. So this is the total velocity time integral. So this is integral of all the velocities of this RBC which are going out of the aorta. Okay. So we have the VTI, we have the heart rate. So we need to now know the radius. So to calculate the radius, we need to go into the parasternal long axis view. So parasternal long axis view. So this is the left atrium, this is the aorta, and this is the left ventricle from where the left ventricular outflow tract is coming. So you can see the valves of the aorta are now, the aortic valves are now open. So just measure just before the aortic valve root. So I'm just at the aortic valve root. So this is 0.57. So we need to do 0.56. So we need to do the half of it. 0.55 or 0.56 divided by 2, that is the radius, and square of this. 148 is the heart rate. So pi r square, I'll calculate it for you. Just so this is pi r square is 3.14 into r is point. What is r? 0.2526. 0.26 into 0.26. I'll do the calculations. Into 0.26 into 0.26 into 10.8 is a VTI into 148. 148. 339. So it is 340 divided by the weight. Weight is 1.1. So it is 308. So it is on the higher side, but not out of the range. So it is just beyond 300. So the cardiac output is increased. Is it beyond 300 or 308? So just increased. So now let's see the LA ratio here. So we are in the parasternal long axis view. So we have the same view. This is aorta. This is the LA. By eyeballing, what you see is just eyeballing. What you see is this is aorta. This is LA. LA seems to be bigger than the aorta. Once you put the M mode at just at the where the valves just open, and so what do we calculate here is the LA ratio. So what is the LA ratio is? You have to measure the LA. You can see this is the aortic valve. This is just opening and the aortic valve is closed here. So you have to measure in between this box, this aortic valve and this box. So this is the where the aorta is measured. So I go to the calculations. So I have to do the LF, sorry, AO first. From the this search to this search. So this is the AO. AO is 0.57. And the aorta, the LA has to be measured in the diastole. Okay, let me save this. Yeah, let me save this. So the diastole is where the aortic valve is closed. So it is coming out to be 0.92. So 0.95 is the LA divided by 0.55. It is coming out to be 1.72. So we have LA ratio which is increased to 1.7. The cardiac output was 3.8. The cardiac output was 308. And we have, you can face towards me. Yeah. So we have cardiac output which was increased. We have the this LA ratio which is increased. We have IVRT which was normal, 50 to 55. Then we had this LA LV was increased, size was increased. Mitral valve, there was only 1 plus was a MR. EA ratio was increased 1.1 to 1.2. I think that's it. So we have completed 4-chamber, the 5-chamber view, and with the plaques view. Fine. So we know now from this, what do you feel if we find a duct or not? Now we go to the next part. We find a duct or not. So there are some parameters which are favoring and some parameters which are not favoring. So I'm going to the ductal view. I can show. So I'm in the currently in the 2D. Let me put a color over here. On or down there. Just a minute. Before.
Kamal, can you show the probe where you are putting the probe?
Yes, sir. Oh, बेबी बहुत हिल रहा है सर. So I am in the suprasternal view, and pointer is pointing towards the 3 o'clock position. Sorry, pointing towards the 12 o'clock position, and I just tilt. Just a minute. We are putting, sir, just we are putting the gauze so that maybe. So now it is pointing towards almost like 12 to 1 o'clock position. Just a minute. Let me settle the baby first. Yeah. So I'm at 12 o'clock position, sir. Lightly 12 to 1, I would say. Now you should. So what I'm finding is this is the descending aorta, this is a pulmonary artery, and there's a red flow which is coming from here. So this seems to be a duct. Let me clarify this. Yeah. So there is a duct which is flowing, and there's a continuous flow which is seen in the as a red flow. So there's a duct over there from the aortic end towards the pulmonary end. If I just stop it and then scroll it, I can see there's a blue and the red flow together. So it looks like a more of a bidirectional shunt. So this is okay. So I think everybody can make out there's a duct which is showing a continuous flow over there. I'll do it again. Yeah. So I think this flow, red flow, and then this makes the blue flow at the same level. So which it makes it a bidirectional shunt. And this is the point where it is just entering the pulmonary. So I have to measure the duct size over here. If I measure it over here or in here from the this aortic end, it will be. It looks to be like spilling over, and it will be like looking a big duct. So this is the best size they can measure. I should hide the colors over here, and this is a spur, and I will measure the duct here. Around 2.5 centimeter size. 2.5 millimeter size, sorry. Okay. So now let's check the velocity over here. What that put away? I'm in the Doppler now, in the pulse rate Doppler. I'm getting the flow in this, but I'll try from the other view where I'll get a better Dopplers. So that is the short axis. So I'll be more aligned, better aligned with this part. I have to just keep before it enters the pulmonary, because otherwise I'll find the whole spill over there. Continuous. So we are getting little higher velocity, so we'll change to continuous mode actually. I think we are in the pulmonary parts of it. Yes, sir. So the velocity is actually going beyond to, and I don't know why this baby is now. वही करना चाहता हूँ पहले continuous से पहले I want to show in the अच्छा I have to shift to the continuous. Yeah. Okay, so now the velocity I got the. So the velocity which I'm getting here is nearly 317. So velocity is 314, which means it is more than 2. The pattern is like, you can see this pattern which sir has told you. Pulsatile pattern. And you can see some, I will go to the pulmonary doctor after this. So pulsatile pattern with velocity beyond 300, which tells you that this may be like a closing duct.
Yeah.
So then,
so this is, you can see, first you can see very nicely he has shown you that the peak velocity is 3 meters per second. So more than 2 meters per second. That's why it was having difficulty in getting it with the pulse wave Doppler.
Also.
So that's why very nicely and correctly Dr. Kamal shifted to continuous wave Doppler, and the peak velocity is more than 2 meters per second. So that means it is small constrictive duct, and the diastolic flows which you were seeing were bit in the middle of from the line, baseline, not touching to the baseline. So that was kind of restrictive pattern what is being seen. So if you just don't see the pattern and see the just peak velocities, and if the peak velocity is less than 1.5 meters per second, it means a large duct. 1.5 to 2 meters per second is a moderate or closing or a restrictive duct, and more than 2 meters per second, it is a kind of closing duct. And very nicely has been demonstrated that. Thank you, Dr. Kamal.
But luckily, this baby has PTA. We were like thinking that must have closed because we gave this baby paracetamol. This baby now you can see this baby is this baby is oxygen now, off ventilation, off CPAP, everything. But still, the duct is there, which is actually we can calculate if it is hemodynamically significant or not with these parameters. So I can show you the after this the flow in the pulmonary. That's what I'm saying. The pulmonary. Okay. So if we put see in the pulmonary artery, the color. Then we see the Doppler over here. Shift over. I think we can also appreciate the three-leg stool appearance: the PDA, the LPA, and the RPA. I think can everybody make it like this? So this is three-leg stool appearance. This is the PDA. So this is the LPA, and this is the RPA. Somewhat you can make it from here. So if I put a color over here, so you can see there are some diastolic turbulences over in the LPA, which is the velocity is nearly 71. So if it is more than 50, so it is a so if it is more than 50, then it's a mild duct. So mild to moderate. So if it is beyond 150, then we say the moderate duct. Okay. If you want to see it is less than 30, 30 to 50, and more than 50. So it is come out to more than 50. So it is going towards the severe diastolic. Okay. So then we want to see if there is any ductal seal or not. We go to the SMA flows. Just point it. So pointer pointing towards the 3 o'clock position in the subcostal view and towards the left side. So you will see the they don't like the subcostal view. So just a minute. Next to now. Focus कर दे। They're trying to pacify the baby actually. They don't like the subconscious views. That's why we do the subconscious view in the last. So this is the aorta, and you can see you can see a Y will be formed over here. This one. I'll try to zoom it if possible. Yeah, you can see this Y. So this is celiac and this is the SML. So baby is not cooperative actually. बड़ा हो गया सब आ गया. Whatever best I can get, I'll do that. So. नहीं आ रहा. Sir, baby is moving a lot actually. Sir, I'm not able to get that well. We can do the Dopplers of the ACA, we can do the Dopplers of the this to see for the vector C. So if I do this, I have to get in sync with this. So you see there's a good systolic and diastolic flows are present. So the ductus seal is not there actually. So from this parameters actually, it feels that this baby has a mild to moderate duct, not a severe duct, because there were signs of pulmonary overperfusion, and the ductus seal was not there actually. But there was some diastolic turbulence which was happening in the pulmonary artery.
Thank you, Dr. Kamal. There are few things in the
Yes.
question answers, and the people want to see where to place the probe for EA ratios and IVRT.
Okay. So I'll do it again. For the EA ratio, it has to be put just below the mitral valve, just below the mitral valve, in the 4-chamber view. So I'm in the 4-chamber view now. The pointer is between 2 to 3. And now this is like a straight. I'm in the non-inverted view. So this is Doppler, just beyond the mitral valve. I can invert it also. I'll show you that also. So just below the mitral valve. अब बच्चा गुस्सा कर गया सर. You are seeing this EA wave, EA wave, EA wave, EA wave, EA wave. So I was just below the mitral valve. When I calculate the IVRT, then I am between the 4 and 5 chamber. Here also you can see it was actually 4 and 5 chamber view only. So I just tilted like this and the aorta opened up. I put a color over here. So you can see both the colors, the red color and the blue color. So blue is going out. So I put my cursor over almost here. They want to know the cursor, no, sir? Where to put the cursor?
Yes. So this is the right position where you are putting it. Yes.
This. So you can see both the red and the blue flow now. So this is the end of the outflow and this is where the inflow starts. So let me calculate the IVRT again. So mitral valve. Sorry. IVRT was once we calculated earlier, it was not coming beyond 50. Yeah, this is a better one. Yeah, exactly 50, same, 45 to 50. So it was where the red flow was coming down into the, so red flow means coming towards the probe. So it was coming into the left ventricle and the blue flow means it was going out. So just between the two, I just kept that my gate. So range gate was at that point. So what here? So where?
Yeah. Thank you very much. Nicely cleared. So there were few comments that people, when you were doing it, and rightly many people told like angle of inclination, it has to be in line, and that Dr. Kamal very well aligned it by making the image
Changing.
inverted. So that is what he took care of that. And cardiac output LVO people wanted to repeat LVO.
So LVOT is LVO, left ventricle outflow, is calculated as pi r square, where radius is of the aorta, and we calculate that in the Planck's view, and then multiplied by the VTI, that's the velocity time integral, that we calculated the velocity time integral, and multiplied by the heart rate. So the heart rate has to be taken before you start the examination, otherwise it will increase. So when I was doing it was like 148 before that, and now it is 150, 158, 6 also it went. So it increased to that point. So pi r square, that is 3.14 multiplied by 0.25 multiplied by 0.25, that is pi r square. That was what we calculated here. Into the VTI, which was 10.6, and multiplied with the heart rate 148. That turned out to be 330 divided by the weight, and that is basically the left ventricle output or the left ventricular index, actually. So we use them as synonymous, but actually left ventricular output is not multiplied by the weight, and left ventricular index is when we divide it by the weight. That's it.
Okay, sure. Thank you.
Thank you, sir.
So till the time Dr. Eugene joins, Dr. Kiran, you are there. So thank you very much, Dr. Kamal. You can stay there. You can instead showing you can answer few of the questions. There are many questions.
Sure.
Like there are 143 questions are there. It won't be possible to answer all that, but till the time we wait, we will try to solve these issues of few of the questions we can take. Dr. Kiran, are you there?
Questions kahan pe?
Yes.
No, yeah. No, I will keep on. It is on the dashboard on the other side. You will not be able to see the questions. I am able to see.
Okay, sir. Okay.
So they wanted like you showed ACA Dopplers, isn't it? So they wanted to just know you can just repeat the view in which you showed them the ACA Dopplers.
ACA Doppler. That was a sagittal view, sir. The middle sagittal, mid sagittal. So they want to see it again. Yeah.
If the baby is there, yeah, you can show them, please. Thank you.
So this baby was actually due for feed, so we are not skipping on the feed for this baby. Okay, everybody is able to see. So the pointer is pointing towards the 12 o'clock position. So just putting over here, and then we shifted the exam to the neonatal mode. So this is a view where you see the ventricle. So anterior cerebral artery is somewhere here. So put the color over here, but be very sure when you put a color over here that the velocity range is less. If the velocity range is more, you will not be able to see this. You can see this ACA. It is circling around. Yeah. So put a Doppler over here, the range gauge. It should be in line. Just in line with, I'm trying to make it in line. So this is a AC Dopplers. So this is a ACA Dopplers. You can see this is a systolic and this is a diastolic. You can calculate from the trace. You can calculate by the calipers. You can use. So we can calculate the ST ratios over here. So you can easily see that the systolic and diastolics both are well there. So there is no ductal seal which is happening here. So that answers the question, sir.
Yes. Great. Thank you very much. So mainly there were the questions regarding EA ratios, IVRT, and ACA you have already answered and showed. So there is one question. Is it necessary to treat when there is pulmonary overcirculation before it worsens to systemic hypoperfusion?
The answer is not that very easy if you ask this, but we have a scoring system where we calculate the echocardiographic parameters and the clinical parameters. So there is an article in the by Dr. Arvind Sehgal. Sir ने इसमें सारा वो parameters बनाया. So he calculated like E1, C1. Sorry, I should point towards me. So we that is E1, C1. So E1 is a parameter where you find no duct. C1 is there is clinically there are no features. Then E2, thus there are parameters which like the duct diameter is between 1 to 1.5 and the duct diameter is between more than 1.5 to 2. Then keep on increasing. So like you reach up to E4. So E1, E2 is I have opened that article. So that this is the articles. Yeah. So E1 shows no evidence of ductal flow. E2 shows small non-significant duct that transductor diameter is less than 1.5, restricted continuous diameter more than 2 meter per second, no signs of left to right volume loading. In the moderate HSD, a transductor diameter is between 1.5 to 3. So these are the parameters. IVRT is EA ratio is more than 1. For C2, for the clinical parameters, it is like there is bradycardia desaturation. C3, there is oxygenation difficulties there. So this is the article which actually we see always that should we treat or not. So you can't treat only on the echocardiographic parameters. That would be wrong actually for on our part. That may be a closing duct. There are some like in this baby also we found some parameters which showed like a moderate, which were like mild, and one parameter was going towards severe. So overall, this baby fitted into like a mild to moderate duct. So, and this baby is clinically, you can see feeding well. This baby is on OG feeds, gaining weight. Not inappropriate weight gain was there. Appropriate weight gain is there, around 15 to 20 grams per day. This is happening, and off oxygen. So I should not treat this baby because the clinical parameter doesn't favor, and my echo parameter says mild to moderate.
Yeah, I think Kamal answered most of the things. Just an addition thing, I think when you decide to sit clinically, I mean, those criteria are applicable for clinical treatment, also for ligation, those C1, C2, C3. But again, when you are bedside and you have a clinical question, okay, you are ventilated now, your ventilated parameters are not coming down. Along with that, you have a signs of over circulation. Then you would choose to treat. You have a baby who is feeding intolerance, and then you have signs of hypotension, then you would choose to treat because you're seeing some clinical signs also. So it's not the echo criteria. So what even Dr. Kamal was trying to address is the echo and clinical correlation. If you're worried that this baby might bleed and you're sitting on a big ductus with all the signs of pulmonary overcirculation, there is a tendency this baby might bleed. Then I would choose to treat. So it's like that. So it's a clinical echo correlation which you decide based on when you follow any score. But it's again that clinical and echo judgment which you can decide bedside. I hope that answers the question. Dr. Mohit, we have more questions.
Yeah, we have more questions. So, just a second. So, Dr. Susan wanted to know how to differentiate between right to left shunt across PDA due to PPH and several PH. So this is a bidirectional shunting which she wants to know. I will just show that because I skipped intentionally. I will show the PPHN like bidirectional because that it becomes more relevant in that becomes more in PPHN babies where you have again bidirectional shunting.
Luckily, this baby had a PDA, so we could actually do all the
Yeah,
parameters.
it was very good. It was very good. It was very good to have this baby and then see that. I hope you are seeing my slides.
Yes, sir.
Yeah. So in this, you can see there is in both systolic and diastolic phase, your pressures on the left side are higher than your right side. So that's why there will be a pure right to left shunting. Okay. So that will be red and the tracings will be above the line. So if suppose in diastolic phase, your right sided pressures increases more than your diastolic pressures on the left side. So what will happen in systolic phase where the aortic pressures are higher than the pulmonary pressures, the shunting will be left to right. But in diastolic phase, the shunting will be right to left. So it will be a bidirectional shunt like this. In systolic phase, it is left to right above the line. In diastolic phase, it will be below the line like this. So it will be like blue. So you will have red and blue color. You will see red and blue color. And this is how you will see the Doppler tracing. Sometimes it will be up, sometimes it will be low. So now the thing is, you have to look for the percentage, that how much percentage is right to left and left to right. So there, what is the criteria is like your one cycle starts from here and it ends here. So this is the one cycle. So suppose this is 100 milliseconds. Suppose because on x-axis there is time. So this is your left to right and this is your right to left. So then you take the time, time in which the shunting was right to left. Okay, and this is all 100. From here till here is 100, and from here till here it is 100, and from here to here it is right to left. Suppose this is 30 milliseconds. So 30% of the total cycle is right to left, 70% is left to right. Till your right to left component is less than 30%, it is mild PPHN. If your percentage of time of right to left is more than 30% of the total cycle, that means this pulmonary hypertension is significant. In that case, you should avoid closing the duct. You should not close the duct. Otherwise, if it is less than 30% and 70% and above is more than 70% is left to right, you can close that PDA if required. So this is the criteria we follow. So in this, you can see there is a bidirectional shunting, where in systole, your aortic pressures are higher than your pulmonary pressures. It is left to right. In diastole, your pulmonary pressures are higher than your systolic pressures. It is right to left below the line. And then in this case, you see in systole and diastole, your pulmonary pressures are higher than your aortic pressures. So the whole PDA is shunting right to left. It will be blue in color and the tracing will be below the line. So that is your severe pulmonary hypertension. I hope this clears the doubt of the people. Shunting of the ductus, left to right, right to left, bidirectional. So okay, so people have been asking regarding the pulmonary hypertension and treatment. So we will have a symposium of PPHNs on like this, how we had a PDA. So we'll discuss all those things like there. So there is a question. Dr. Kiran, everybody, Dr. Kiran, are you there? Dr. Kiran? Dr. Kamal?
Yes, sir.
Yeah, are you there? You are there. Yeah. So in HSPDA, if diastolic blood pressure is low, is that significant, and whether it is indication to start inotropes? Is so, which one, dobutamine or noradrenaline?
No, you mean to say for only if there is a PDA and if there is a diastolic flow is low. So usually in a PDA, that the diastolic runoff happens, na? That is the ductal steal.
Yes.
That is what they want to ask, sir.
Yeah, basically, like there was a question before also. So, and there was a very good comment in by the people that if the ductal flow, if there is a HSPDA, then there is a ductal runoff and there is a wide pulse pressure. So
Yes.
therefore, what happens is your diastolic pressures will be low. Hence, it will bring down your mean blood pressures. So that's why there was a comment in the comment box that we should not follow the mean blood pressures, or if you want to look at the systolic blood pressures,
Systolic blood pressure.
and does not take any action on the basis of mean blood pressures.
Mhm.
If at all the baby is in shock, yes, you can start with the dobutamine, but you should avoid vasopressors like noradrenaline or dopamine, where it will cause vasoconstriction and hence that will increase your left to right shunting. So it becomes detrimental. It may be detrimental for your tissue perfusion. So therefore, in PDA with shock, you have to be very careful in deciding and treating the hypotension. If your perfusion is okay, urine outputs are good, lactates are fine, and your systolic blood pressures are okay, you just sit on it and try to close the PDA, treat the PDA. That will be the recommendations. So, Dr. Kamal. Dr. Kamal?
Yes, sir.
Okay. Yeah, there is a question. Renal artery Doppler flow can be used for the systemic perfusion?
Yes, they can be used, but they are very difficult to do in a newborn baby because they do.
Yeah, please.
Yeah, because bacha, like even in this baby, I was not able to actually get the SMS flows because the movement was so much, and the vessels are so thin that you have to focus there, and then you get a good view. The baby has to, I think, stop that breath for some seconds, then only it gets value. So renal Dopplers can be done, but it's really difficult to get to do in the newborn babies. They're not like currently used as standard. We use the ACA and the SMA flows.
Correct. And just to add, those babies with renal compromise often will have a aortic steal as well. So we had few babies where ligation was done or a device closure was done because the baby had persistent renal failure with a persistent aortic steal. And as Dr. Kamal mentioned, renal Dopplers can be done. In fact, we study on that, but it's very tricky. And if there is a renal steal, there may be possibly an aortic steal also. Those with aortic steals tend to have renal failure, so that is a significant steal. So
your voice is breaking, Kiran. Kiran, your voice is breaking.
Aortic routine, isn't it? Okay. Now I was just saying that I think the network issue probably. What am I audible?
Yes, now you are audible.
Yeah. No. Okay, I will turn the video off. I was just saying that generally babies with renal failure, what we have seen is they will have aortic steal also. So aortic steal is there, and if there is a renal failure persistent, that could be contributing to the PDA. Renal Doppler per se is not very useful and probably not required to be done routinely. So I was just sharing that, we had one or two babies who required ligation or device closure just because they had persistent aortic seal and renal failure, which was not improving. And it improved after the ductal ligation. So, aortic seal probably is a good significant marker for renal ischemia than the renal artery seal. But there are not many studies looking at those actually. The aortic seal and SMA celiac probably routinely one should do. And MCA.
Thank you very much. And so there is a question, Dr. Kamal. For pulmonary VTI, we need to calculate it in LPA or main pulmonary artery.
We calculate in the main pulmonary artery.
So, like, this is very appropriately asked. Ideally, it's from the bookish, this thing. If you go with a strict bookish thing, it has to be in the LPA. Because, why LPA? Because ideally, anatomically wise, this PDA is entering into MPA towards the LPA side. So that's why ideally it has to be done in the LPA. But most of the time what they've seen is the Dopplers, they are almost similar in MP and LPA with slight difference. And it is easier to do in MPA as compared to LPA. So people, they do in the MPA also for the Dopplers for this pulmonary artery Dopplers for PDA. There are so many questions.
Very enthusiastic crowd. Huh?
Pardon?
Very enthusiastic delegates.
Yes, already 160 questions are there.
Oh
Can
my
we
goodness.
can we say that MCA steal happens once you see aortic steal? Dr. Kamal or Kiran, whoever wants to answer.
No, not necessary. Sometimes you
not
see
necessarily.
yeah, Dr. Kamal, you can say, but I think MCA still can be still present without even aortic steal. Not always.
Not
Both will be
always.
there. No.
That's why we check in the different arteries. So what is happening in the SMA, what is happening in the duct, this aorta, what is happening in the MCA. So we have to look for all the arteries actually.
So if the location of the ductus is below the origin of carotid vessels, will HSPDA still can cause steal of cerebral circulation? Wow. Nice question.
Yes, definitely can. It can. That's the whole. So steel can be forward and backwards, both the direction. It can steal from the renal systemic and also from the MCA. And we have many echoes.
Sorry, your voice is breaking. So this is very appropriate because we always thought that we do it from the descending aorta. That is after where you get, third branch is ending. And then around 1 to 1.5 centimeters below that. So that is a isthmus of the aorta from where the duct arises. So we always think that the ductal steal is happening from the descending aorta, but actually it is not correct because ductal steal is also happening from the cerebral vessels, upper part of the duct also. It is both bidirectional, both upside and down, both. So that's why the ductal steal will still happen. So that's why when the PDA becomes small, the steal which was been happening will get reperfusion, and then you get higher chances of IVH in that case.
Dr. Mohit, I was wondering, should we start the session like the panel right now and then start addressing the question in the panel only? Like we can rotate the additional to the panel questions, we can answer all these queries.
Yes, because I kept
Dr. Venkat,
yeah, because there were few questions I have already parked for the panel. So yeah, Dr. Venkat is already there. Dr. Dinesh is there. Dr. Rajesh sir is there. Tejo is there. Only Surjit is pending.
Because I think Dr. Yogin and Dr. Arvind, because of the time difference, I don't know whether
no, actually, I just chatted, like he had some issues, Arvind, but Yogin, I just chatted. He was about to log in. I don't know what is happening to him.
To log in. Okay.
Okay,
yeah, then
fine.
we can have his talk
No, we can start. We can start with the panel, and then we will just see. I will just call Surjit, else everybody is there. So Dr. Dinesh and Rajesh sir. Sir, are you there? Dr. Venkat is there. Tejo is there. So we have Dr. Venkat with us already. I'm just calling Surjit.
So Dr. Venkat, you can take over now and we can initiate the panel for now and then Dr. Yogen's discussion can happen. Changing the sequence.
Hi, good morning to you all. Good morning, Mohit. Good
Morning. So
Good morning.
with you all.
I'm just calling Sujit, and then I will do a introduction for everyone, and then Dr. Venkat will take over. Already there is a lot of this thing, Dr. Venkat. There are almost 160 questions. I have already parked around 10 questions for you already, and rest we try to answer. So
One query, like how do we see the questions? Because I couldn't see any of them.
yeah, because the thing is that is in the dashboard. That is a different, because you won't be able to see how many participants are there and what are they writing. So I will be either, if you want, I can speak the questions, or I can paste it in the chat box. I can do that.
One option could be that we can get going with a set of questions. What I made actually, that some 10, 12 questions to the.
Yes, you can. I'm just calling. I don't know why everybody is offline.
Dr. Dinesh, good afternoon.
Hi, good afternoon, Dr. Venkat.
बड़े लोगों को दर्शन मिल रहा है आज.
अरे बड़े सभी बड़े हैं. कैसे? How are you, Venkat?
Join कर भाई.
Doing good.
A good session so far.
Yeah,
Hi,
yeah.
Tejo.
So Tejo is there. Great.
Rajesh was there in the morning.
He was there, I think. Dinner also he was there, sir. I think.
Tejo, we couldn't hear you. Sorry, you said something.
Rajesh sir was there, sir. Now he
He's
just
there.
left. I
He's
think.
joined. Dr. Rajesh, good afternoon.
Good afternoon.
Yeah, he's there.
So, good afternoon, everyone. And this is now we are going to start with the panel. There are a lot of questions already, but it will be an interesting panel because there is a lot of query already generated. So for this panel, we have Dr. Venkat. He is a professor in PGI Chandigarh in neonatology, and he is with us from last 10 years or more. And we have been conducting and doing this point of care ultrasounds and functional echoes. So welcome, Dr. Venkat. He will be moderating this panel. And then for this panel, we intentionally have kept two younger neonatologists who are whose mind is just stuck with the hemodynamics. And then two very experienced, very prominent neonatologists, Dr. Rajesh. He is the head and director of neonatal, a big neonatal unit, more than 100 beds in Ranchi, Rani Children's Hospital. And then we have Dr. Dinesh Chandra with us. He is the director of neonatal and pediatric intensive care services at Rainbow Children's Hospital. So he is there with us. And then in the panel, we have Dr. Tejo. He is a neonatologist in charge of Fernandez Hospital, Hyderabad. And then along with that, we do have Dr. Sujit Madan. She will be joining. And she is running an NICU and she is a neonatologist practicing in Jalandhar. So welcome all. So over to you, Dr. Venkat. So after your discussions, please everybody be there. There is a lot of questions and queries already has been in there in the chat box. So I will be speaking out because there are more than 160 questions in the chat box. So we will those who are get resolved by your remaining we will discuss. Thank you, Dr. Venkat.
Okay, so I welcome to all the panelists once again, esteemed panelists. So we have, I think all four of you are senior people only. So Dr. Dinesh, Dr. Rajesh, and Dr. Tejo and Dr. Surjit. Surjit is yet to join. So the plan was, what I thought is that I framed some common 10, 12 questions, like more of a clinical oriented questions. Some are in relation to like diagnosing, some are in relation to picking up the so-called hypodynamic significant hemodynamically significant PDA, and some are in relation to management common queries. I was not there in the morning sessions. I'm not sure exactly, probably many would have been covered already, but some might have been repetition, some might have been left out, so we can take them. So I thought I'll go one round of questions to all 4 of them. So since Surjit is not there, let me start with Tejo.
Sujit has joined. Sujit has
Surjit
joined.
joined. She has joined.
She joined.
Welcome, Surjit.
Unmute Surjit. We have already done the introduction and everything is done. So Dr.
Okay.
Venkat is starting with the questions.
Yeah, fine.
So it's like more of a sharing experience. I guess you all have been seeing PDA as a problem for the last more than 15, 20 years. So, and I'm sure PDA management has evolved. Picking a PDA as a diagnosis evolved over the years. Like we used to have times when we didn't have an echo machine, all were clinical significance, clinical PDA, and end up managing. We had indomethacin to begin with. We used to have smuggled indomethacin to begin with. Then again, Brufen came into picture, oral Brufen, and now paracetamol last 4-5 years. So it was an evolutionary phase. Let me start with Dr. Surjit. So like Surjit said, common question is like, for example, I'm a young neonatologist who will just learn to do an echo. I am not really well versed in echo. Attended few workshops and trying to get some hold on echocardiography. So now, like say, he's asking you that you are a senior pediatrician, come neonatologist, and he's asking, can you tell me some clinical and echo signs, like which are very reliable to predict a significant PDA. So, because usually they keep asking the rounds also that which one is important. I keep finding some hypodynamic precordium. Somebody says there's a murmur. Somebody says the size is important. Somebody says you should look into the PDA and look at the signs and all. So, what do you feel that maybe scientifically or from your experience, you're seeing that these signs are present more commonly than not, where the PDA becomes significant?
Yeah, so if a baby is preterm and then I might think that any deterioration or any change in the clinical signs and symptoms, one of the suspicion would be PDA. Like the clinical signs of PDA usually depend on the amount of the shunt volume which is passing through the ductus, and which might depend upon the systemic and the pulmonary resistance, and also depends on the myocardial adaptation. So adaptation to the shunt which is going on. So I would like the few common signs and symptoms would be tachycardia. There might be or might not be a heart murmur. Then the chest might be hyperdynamic. There might be a bounding pulse or hypotension, or there might be a deterioration of the respiratory status, maybe around 48 to 72 hours if a preterm deteriorates, or there is some apneas, or there is worsening of the respiratory status. Then I might think, or I might suspect PDA, or when I check the blood pressures, there might be a wide pulse pressure. So these are few of the clinical signs and symptoms which I might suspect a PDA in a preterm baby.
Okay. Now this all depends on, does it depend on the postnatal age also? Like say a day 1 baby versus the day 4 baby? Or does it all depend on the comorbidity? Like somebody is septic, another newborn has pulmonary artery hypertension, those clinical signs will change? Like what do you think about that?
Yeah, definitely. If a preterm is a septic or there is pulmonary hypertension, then the clinical scenario might change. Any baby who is deteriorating, I will suspect other diseases also like sepsis or maybe PPHN. There might be a pneumothorax. The other symptoms are also important, or other differential diagnosis is also important. Few other things like if there is feed intolerance, because we know in a PDA there might be NAC, or there might be a feed intolerance or renal involvement, or that is so later thing, like when you go for an X-ray, there might be a cardiomegaly or pulmonary edema, and any hypotension or metabolic acidosis might also be associated.
From your practice, like from your experience, so which one direct clinical feature of a PDA which you feel that, okay, if that is there, I'm really more concerned about a significant PDA, leaving aside the other clinical manifestations. So directly clinical feature of a PDA, like say this is their indicator of PDA and it may indicate more towards significant PDA, and any one or two very important echo signs out of all the big list of echocardiography signs. Okay, if these one or two are there on an echo, then I'm really concerned it could be a significant. I'm sure it's a difficult question because we don't really have a clear answer for this. People are striving to look at all various scoring systems and all. So maybe you can tell from your experience.
Yeah, so if I am suspecting a PDA, so I would just on the basis of the clinical signs and symptoms, I would not like to treat it, because any baby without an echo, we should not treat a PDA, because if there is some cyanotic congenital heart disease or there is some duct dependent congenital heart disease, and if you close the PDA, then the child will suddenly collapse or might deteriorate. So I would first like to do, okay, X-ray, so definitely we'll go for it, and then do echo. And then there are few indices. I'll just highlight important ones. Definitely, I will see the size of a PDA, what is direction of flow, whether it is left to right or right to left. And then whether it is a restrictive PDA or it is an unrestrictive PDA. And then a few points of pulmonary hyperperfusion and systemic hypoperfusion. I will look for LV dilatation. That is very easy visually. By eyeballing, you can make out that there is LV overload. And a LA-AO ratio in your plaques view, if it is more than 1.4, 1.5, then it signifies significant, maybe a moderate or large PDA. And to see the signs of systemic hypoperfusion, I would see for a ACA flow. Dr. Kamal must have shown you these indices how to do. So if there is absent or retrograde flow in ACA or the SMA, then these all are points of significant, hemodynamically significant PDA.
Okay. So probably size and a larger left atrium and presence of a steel actually would caution you there is significant PDA, right? This combination you feel that is important. Okay, Tejo,
Yes.
Dr. Surjit said that she may not be comfortable in treating with clinical signs alone. She wants an echo because clinical signs may generally misguide us. But what is your take on this? Like say, if there is a signs of typical of a very big PDA, like hyperdynamic pericardium, bounding peripheral pulses, a really wide pulse pressure, or combination of this, and there is no echo machine, no echo expert is there available. Should we still consider starting a first course at least while we are waiting for an echo by somebody, some expert arriving at your center and doing that? Tejo, what do you feel about this?
Thank you, sir. As we just now, Dr. Sujit also told, you are able to hear, sir?
Yeah, I'm able to hear you. Please carry on. Yes.
Are you able to hear?
Yeah.
So the main problem with going with the clinical signs alone is that the clinical signs which are consistent with PDA are not these specific. They can have with different other clinical syndromes in the neonatology also. And there are a lot of inter-observer variation which can be there. And the lag period for having the murmur, which is more specific, is very much. And so these are the main problems when you look at the clinical signs alone taking as a condition to start the treatment. Second problem that we need to always remember is that is there any ductal dependent lesion that is there, and then we are closing that for the baby, then the baby can go into major crisis. So these are the two background points that we need to take it. However, when you are having all the classical signs, but by the time majority of the damage also might have started, then in those conditions where you don't have the machine ready or the machine, the cardiologist is coming from outside, maybe the first dose you can give, but you wait for the second dose before taking a call. It's a practical solution. I'm not saying that this is what we need to do it, but this is how we can go for it when you have doubt about the same. Yes.
I fully agree. I think probably both are pointing out towards not treating a duct with only clinical signs, should preferably have an echo signs. But the point Tejo is making is very important because you may not have an echo machine bedside all the time. And if it is a really troubling PDA, and if you're sure about all the clinical signs, you may give actually a dose or two, but try to get the echo done as well as possible, considering there can be duct dependent circulation, it can harm much. So I think it's a practical solution also. Let's hear something from Dr. Rajesh also, because we frequently encounter extreme preterm newborns, like who get the pulmonary surfactant in the first hour of life, and they apparently settle on low to moderate CPAP. It's a very common scenario. And the newborn develops pulmonary bleed. Usually happens pulmonary hemorrhage, which can be massive to moderate pulmonary hemorrhage, and worsening respiratory distress, end up requiring intubation and all those complications. Now, is there a role to start treating PDA in those conditions where there is a surfactant, extreme preterm, pulmonary hemorrhage combination without an echo? I'm trying to reinforce again without an echo in all three questions because we conduct workshops, we conduct symposiums all over the country, but still having a dedicated echo machine is not still actually there in all the places. Maybe after the workshop, one can go and get trained and get confidence and try to procure an echo machine. So it will take maybe a few hours to half a day also to get an echo done. So Dr. Rajesh, what is your take on this? Middle of the night, pulmonary hemorrhage, got pulmonary surfactant, extreme preterm baby. So no other clinical signs.
I know this is a perfect situation for suspecting a PDA creating problem. We all know the incidence very high, like baby 900 grams at 260, 60% baby will have PDA incidence maybe. And on top of that, you have given surfactant, you have decreased the blood pressure in the pulmonary circulation. Again, left to right shunt will be increasing because of decreasing pulmonary hypertension. So it is a perfect situation. Like we'll have most probably this bleed is because of PDA. And in the middle of the night, if echo is not there, or resident is there, is not comfortable with doing echo, obviously we'll start the treatment. And we used to do it, like we are almost 30 years now in neonatology. And that time it was a lot of confusion. And that time we used to have a echo machine. That time, like we are doing echo for like last 30 years, maybe 94, 95. We are doing. That time we used to have only the no color Doppler, nothing, only LAO ratio. That was what we used to depend upon. And that also used to be done by the DM residents, not by the MD students. And then this is a situation where we have a bleed on day 2, day 3, in extremely low birth weight baby. In middle of the night, I will suspect the PDA and I will start the treatment. And also going by the previous discussion, like echo machine is still, there are many NICUs in India which don't have echo machines. There are limitations from PCP and DT Act and also by the training also. And so just disregarding the clinical science and always do echo before starting PDA closure treatment. I don't know how scientifically, we are scientifically correct, but practically we are not correct. Because if you see the babies who are less than say 1.5 kg baby, 1,000 babies, if you have clinical signs of PDA, hardly 1 or 2 will have drug dependent lesion. Hardly 1 or 2, not more than that. So I disregarding the clinical science from my point of view is not correct. It's not essential to get a echo done in practical situation. Many, all of NICU which treat VLBW baby, I don't think more than 50% will have echo. Okay,
Right.
so
I also agree with your comment, sir. Because if the question is that the tricky portion is that in the middle of the night. So plus it's an extreme preterm, got surfactant. So setting is there.
The setting is there, obviously.
All the more reason that it probably PDA is a culprit. So unless proven otherwise, so probably a dose or two might be agreeable. I want to say as same question to Dinesh also. So Dr. Dinesh ka take kya has? What will be your take on?
I have my difference of opinion on that about
See, I think I agree that when we have limitations, we are in a place where we can't get access to echo. We think PDA is causing pulmonary hemorrhage, and probably the focus more should be is splinting the lung, restricting the fluid, trying to go on that aspect of PDA management, rather than being sort of more being in a rush to try to give any of the drugs till you are very sure it is not a duct-dependent cardiac lesion. It could be those extremely one or two. Because, and this is what, but I absolutely take what Dr. Rajesh said or what, Tejo said also, is that, but is it a decision I have to take in the middle of the night? Do I have to at that time, splint the lungs, prevent further bleed, increase the PEEP, or put him on high frequency, restrict the fluid, find out if there is any evidence of coagulopathy, try to fix that? That could be my priority at that time if I have a child with pulmonary hemorrhage. And then, of course, look that PDA is responsible for that and try to fix that uh, by morning and try to see, because more and more as we seeing the evidence which is coming up, both from the recent trials and other things, people are going slowly away from being aggressive in treating the PDA. So people are trying to say that we probably going to buy more problems by treating it aggressively. So are we having enough evidence to say, okay, PDA is causing pulmonary hemorrhage is something else? Have we given more fluids? What is else it is causing? Is what my take is. But absolutely take the point that a lot of these decisions are based on where you are. So I think the message definitely is partly what Dr. Sujit said, and Dr. Is many a times you have to base on what your, is it a hemodynamically significant PTA? Is a PTA creating trouble for you? And then you take a call to treat it. Otherwise, mostly try for conservative management is what I would say.
I think it's a very important actually message. You just nailed the message very clearly that even though you have a massive pulmonary bleed, and even though there is a possibility that it will be PDA as a front runner etiology, and then something else, but definitely fluid management and ventilatory optimization, those take the priority. But yeah, possibly that in the middle of the night, one may consider a dose or two before trying to get an echo while getting done all the ventilatory settings and all. Because I still remember actually 3-4 years back, we had one of our DM students examination. Dr. Ashok Virari came as an examiner, and I was a moderating faculty. I was standing with him. It's an extreme preterm baby. So that baby on the day, examination days, morning actually had a pulmonary bleed and he got intubated actually. He was 700 grams, 28, 26, 27 beaker. So, and we haven't done an echo. We had echo machine inside, not done echo at the time. In the exam, actually, he got little upset and little sounding furious at actually why we didn't start treatment for this baby. We said that echo machine is there in some other area. And he said that you want an echo for this, it's a 27 beaker, 700 grams surfactant, and a sudden worsening pulmonary hemorrhage. It has to be a PDA. Again, see, I'm not saying that we should not optimize. Yeah, so the message looks like you need to optimize the fluid management, ventilatory management, and probably if there is no other way, no way to confirm a dose or two, treatment for PDA might be considered in this. That's what it looks like. So now let me move on to Dr. Dinesh once again. I have one more actually question to Dr. Dinesh.
Just when
Yeah. Dr. Rajesh, yeah, please.
I will just tell you the story what happened with me. It in middle of the night when baby was there, 26 week or 27 week, I forgot, and he started having tachycardia. I started having low blood pressure. So as a resident, as a DMS, MD resident, we thought maybe baby was in open care. So maybe baby may be getting dehydrated. Okay, then we called the consultant on call. She said give classics. But somehow we called our SR. He told, no, it looks like dehydration. You give fluid. And the next day, the baby had full florid pulmonary edema. I went on to have pulmonary hemorrhage, and it was very difficult to manage after that. So that's why this case also highlights a situation like if you have echo, it's better to confirm it. If you don't have echo, obviously clinical science we have to depend upon.
Okay, Dr. Dinesh, I have one question. We know that extreme preterms are at higher risk compared to little bigger preterm babies of having a manifesting PDA, like some clinical signs or echo signs. So is there a role for prophylaxis with any of the NSAIDs? Do you use in your practice or do you advise?
Yeah, I think, see, there was some actually in the morning, Kiran had covered something. And so I'm actually part of the trial when I was during my training in Australia. The prophylactic indomethacin trial was part of the trial. And many of us looked at the recent Cochrane review also. See, many of the studies which have talked about prophylactic indomethacin or brufen, the evidence shows that it does close duct. It does sort of probably reduce intraventricular hemorrhage. It does probably reduce the need for surgical closure of duct. This three seems to be good. But it comes with a problem. It comes with the problems of increased GI problems. It comes with the risk of renal toxicity. It comes with the risk of perforation. And there was some concern about some white matter injuries also. And it didn't make a big difference in the long-term neurological outcomes. So really, when they looked at the benefit, and then they looked at when the conservative management group, also, it was found that some of them closed spontaneously also. So it really came down to a conclusion there's really no role of a prophylactically closing for any of this baby. So that part is, I think, very clear message is given that there's no role of prophylactic closure of any of the ducts. Even to the extent that recent evidence from Benedict trials, all sort of this early sort of expectant management, which Dr. Sameer has sort of also presented, is again of brufen, which has been given. It didn't make a big difference. And if you're giving sort of PDA in the early stages also for the small babies, the outcomes like prevention of bronchopulmonary dysplasia, reduction in mortality, or was not anything big different. So I think in short, we are not using it. The lot of stress is now being given, as was mentioned earlier, is about your fluid management. Keep dry, keep the child dry. And as Dr. Rajesh has said, see, earlier we used to be sort of little probably liberal with the flutes and other things, thinking that a lot of them probably lose a lot of fluid transepidermally. We probably didn't have incubators. Those were some of the things which used to worry about. What is the right sodium for them? How do we manage their fluid? And how do we manage their blood pressure? What is permissible hypotension for them? These are the things which is probably still many of us as the neonatologists have to address. And that is what is probably many a time some people end up giving a little bit more fluid. So message for many of us who are watching would be to keep your babies dry. Don't be in a rush to treat your PDA. But yes, if they are hemodynamically significant, which has been nicely covered by Mohit and Kiran and Aurora from morning with so many these things, I think they are the one whom we, if they qualify as hemodynamically significant PDA, and we think that is creating trouble for your ventilator requirement or this, then we probably have to treat them.
Okay. Okay, nicely put. So basically prophylaxis doesn't seem to have a role in treating these PDAs, whatever significant they may be, because it looks like the possibility of a PDA closing spontaneously is quite high, quite big numbers. Now this brings us to the, if not prophylaxis, you said a word called expectant management. So maybe I'll ask Surjit, can she throw some light on expectant management? What is exactly that expectant management? Like how long you can keep waiting? So like few days, or should we look for some clinical signs? Maybe we can take support of some scientific evidence. So Dr. Surjit?
Yeah, so what we usually do in extreme preterms, we keep monitoring the PDA through our echocardiography. And what we do it on daily basis. And if any time I observe that a non-significant PDA has got converted into a hemodynamically significant PDA, we have the scoring system. We can score it on the basis of echo indices. So what it is known that the echo findings of HSPDA are seen much before the clinical symptoms have come. So if we wait for the clinical symptoms to appear, it means that the systemic hypoperfusion has already occurred and the damage has already been done to the baby. So if on the basis of echo indices, I'm seeing that baby is having a hemodynamically significant PDA. So I would like to start the medical management with the drugs.
Okay, okay. Now, one of the common problems that keeps coming, I'm sure all of you would have seen that you do an echo in a PDA, for example, and you find that the PDA has bidirectional shunt. You know, residents keep telling actually the PDA to hai, but it's very big, like 2.2 mm, but there's a bidirectional shunt with some percentage left to right and some percent right to left shunt is there. Typically in the first 48 hours of life, baby has respiratory manifestations, requiring respiratory support. Now, I am in a fix actually, should I treat or not to treat? Because many times our seniors tell us that duct is for a reason. So the duct is going to help you to bring down the pulmonary artery pressures, don't close it. But another concern actually is that 48 hours, the pressure drops suddenly, then duct can become significant, should I close it? So how do you guide me? Like Tejo, can you address this question, Dr. Tejo?
Very difficult, sir. This question actually, I can say. You're able to hear, sir?
Yeah. You're audible, Tejo.
Yeah. Okay. So the main concern, as now also Dr. Dinesh has told, we need not be too aggressive on treating the PDA. First, basic dictum is that we need to look at it. But at the same time, suppose the situation can come like this, when you are going in the evening and you have done a 2D echo, at that time there is a bidirectional shunt, and then in the night it might worsen to left to right shunt and then go into a pulmonary hemorrhage, which you do not want it to happen by aggressive monitoring and everything. So, initial part of the early part of the neonatal period, we know that many of the babies will have a ductus, which might be even a significant ductus. So we need to wait till it spontaneously closes. We can give a little time for it to close. When, especially in a case where there are more respiratory symptoms and the RDS is bad, the duct will take a little more time to closure. That we all agree upon the same. And when the pulmonary pressures are very higher, and if you have a bidirectional shunt, by closing the ductus, actually we might be doing more harm than the benefit, because it can aggravate even the pulmonary hemorrhage incidence and other things also. So practically speaking, when we are, if you want to treat and if you are aggressive treatment group, if you are there, then maybe at least you have to wait that if the shunt fraction to the left to right is near to 3/4, then we can try to close it. Otherwise, I usually wait till it becomes a little significant left to right and see once you correct the respiratory problem in the baby with a good expansion and good surfactant usage and optimization of the ventilation, whether this will, even the shunt side also might become lesser during that time. And then you can take up a call whether, even if it is left to right now after 6 hours, whether we need to treat it or not. That's what I can put it into summary, sir.
Right. So shunt direction alone may not really help you understand. You want to monitor much more serially, look for more clinical signs and wait for some more hours or half a day more, do more echo. Till then you can manage a fluid management, ventilatory optimization, and then you can have a look at that and decide later. That's again a practical way of managing, because as I said, that shunt might be there for a reason, and probably closing early would not really help and can create more problems also. Now, since Teju, you were there actually already, so I thought probably I'll ask you one more question. There are some papers coming up, no? Like you would have seen that there is in combination therapies. Like, so one drug is not enough, so let's have 2 drugs now, combination. And there are combination routes also. There are people who try to use parenteral and oral. So have you tried any combination therapies in a practice, like you had brufen paracetamol combination? And you found that it works better because they are complementary to each other, different routes, anything of that sort? Anybody for that matter, Dr. Rajesh, Dr. Dinesh, Dr. Surjit, have you tried any time combination therapy in your practice? Like one time it failed, one course you tried add-on drug, something of that sort?
No, like if I've
Till-
started with the PCM, I tried for 5 to 7 days, or maybe I'll continue with then another course of the same drug. So I've done like maybe for 10 to 14 days, but not a combination. Not that.
I am not,
Okay.
Till now, I do not have a personal experience on the same. Yeah, okay. Rajesh sir.
I
Rajesh
have
sir.
not tried, but there are studies
Yeah.
on
So
therapy, and they say that it causes more PDA, but I don't know how clinically significant it is.
Okay, Dr. Dinesh?
Dinesh,
Yeah, not tried simultaneously. I think what is the other question? But there have been times when we said, okay, paracetamol didn't work, so tried Brufen the next
yeah,
time.
whichever is
What sort of, what's been tried? And again, as we said, sometimes it worked, sometimes it didn't work. But slowly we are going away from it and what we said. And probably, are we going for really those long courses is the question which we are really asking. But yeah, I think we can talk it later. But we slowly going away from the long courses. But that is something which we are sort of slowly looking at.
the rationale behind that combination therapy was that because NSAIDs have different touch points, basically COX inhibitors and peroxidase inhibitors. Like paracetamol will act at the different level, and then you have the COX inhibitors, which are like indomethacin and ibuprofen, are different sequence where you can. It's like a sequential blockade if you want to try to do it. Whether it will try to help you on the same, but whether this sequential blockade is required or not, we need to look at it. But some of the ML experiments and other things have been shown some good results. But again, there are RCTs which are only two RCTs which I could able to follow. In that also, total number of babies are less than 300 or 250, and then spontaneous closure rates were also very high in that groups. So with the current evidence, we cannot take this as a practice, but maybe in future we need to see whether there are two ongoing trials which are going on the same, whether they will give any of the good results. Yes.
As of now, combination therapy is not recommended. That's what we all agree, and we haven't tried also. So, number one. Number two, actually, again, when we talk about expectant management, we should not forget, actually, there is one subset, actually, basically, the extreme preemie subset. So they need much closer, actually, monitoring because they have a very lesser rate of spontaneous closure compared to like 27 and less 27 weekers. We do manage, we do see because of a better newborn care all over the country over the last many years. So we are actually managing, saving more 25, 26, 27 weekers. That's the reality. It means that we're catching up with the West. So now that phenomenon has led to a higher BPD also. We are seeing more BPDs, and same time we are also seeing actually more PDAs not closing spontaneously. They don't really fit into that expectant management. So they need much closer monitoring. If the fluid management, optimization, ventilation fails, they may end up getting treatment a little later also. That is one I thought I should add from my side. So I thought probably Mohit has put some more comments and questions from the previous, I think, spillover. So maybe
No, it is your distinct session when it is going on. There are a lot of questions.
so I'll just go through certain questions which I'll just
Yeah, I can tell you, and then you can, whomso you feel it is appropriate, you can ask
I
those
think
people.
put in the chat box. We could read that. I could see that the chat box. Right. So
What I feel, either like you told, there is no access for you for the questions, but I think either they have read your brain or you have read their brain. Almost whatever pattern you are asking, the same pattern they have been asking in the chat box. There are more than 170 questions in there. I just filtered out few of them. Very people are really interactive. They are really if they would have been here, it would have been a kind of all Russian here. So if you
there's
can
one
please.
question from Dr. Nishat Ahmad Liaquat that says that which situation is common, pulmonary overcirculation or systemic underperfusion, hypoperfusion. So maybe fastest singer first, actually. Which panelists want to take this question? You can raise it.
And in connection to this, there was another question that was even asked, like which occurs first? Like
Okay.
whether the hypoperfusion occurs later than the systemic pulmonary overcirculation. So that was in both in connection with each other.
Okay. Who wants to take?
I think I can take that. It's, I think, based on the type of lung we are dealing with, or the day of the when it has become significant, isn't it? If a child is born with a bad lung, if you have a child with a pulmonary intestinal emphysema, severe hyaline membrane disease, probably the left to right shunt will not be that much, and you will have more of another systemic problems in this child because the pulmonary pressures are already higher there. Whereas if you have a decent sort of already the lung is good and then you have PDA, the duct is significant, then your left to right shunt is becomes more, and then you will have then you start seeing more of PDA related reduction in lung compliance, the CO2 will start increasing, then your start will deteriorating. So when you look at echocardiographic changes, or whatever sort of the way we are all talking about today, the systemic hypoperfusion or pulmonary overcirculation is a lot to depend upon not just the size of the duct, but a lot to do with the compliance of your lung and the degree of the lung diseases. That's what has been our experience. We had some, not just with the gestation age, you might have some small babies who have a very nice lungs, suddenly they will show differently. Your slightly bigger babies with poor lungs, they will show differently. This has been our experience. Others can share their knowledge.
Okay. Anybody has a different take on this? I frankly think, actually, I don't really think there is any sequence, like say which one happens first and which one happens second. It's again variable, it's case dependent. And probably if there is as Dr. Dinesh said, if the lung compliance actually is not normal because of like pneumonia or because of hyaline membrane disease, so tend to have a higher pulmonary pressures. So you may not really have a pulmonary hyperperfusion scenario, but probably you may have a systemic underperfusion more common than the other way around. So, but again, it depends on the cardiopulmonary interaction also, because if you have the same babies on a higher pressures and a ventilation, which can further compromise the cardiac output. So that can end up actually manifesting the systemic underperfusion much earlier than what you normally anticipate. So it's a little complex. So, but I don't know what is the clinical, the person who has the question, what is the clinical implication of this? I'm not sure about that. So, but it looks like it's not a single answer to this. One interesting question actually from Steve at screen through. Have you encountered baby with reduced urine output after first dose of Brufen for preterm PDA? And I think probably is getting to a reduction in urine output can be an indicator of therapeutic response. There are some papers on this that you look at the urine output, and if there is an oliguria following Brufen endomycin, so does it mean the drug is actually acting? So the PDA is about to close, so the drug is effective, despite oliguria being not a good sign of the drug itself. So can there be an indicator? Anybody can share an experience. They've seen that oliguria, and they've seen that those oliguric newborns have a much higher rate of closure of PDA compared to non-oliguric response to a drug, Brufen endomycin.
If see more with indomethacin, see, we're not using any more indomethacin in the now in India. But see, I remember during your residency days in these things, when you used to give indomethacin, one of the first things during the rounds was supposed to see what's your urine output next day or the next 24 hours, because there used to be a drop in the urine output. And I think most of it's a dictum is with indomethacin, usually after one or second dose, the duct does close. And you're giving you're repeating the dose more to keep the duct closure patent rather than sort of reopening of the duct. That's what sort of was the teaching. But now we don't have access to indomethacin in India, so that we are not seeing, more and more of us are seeing paracetamol. So that phenomena is not observing. So how much that does mean indication of closure of duct is not, more of a nephrotoxicity, difficult to say. but it does because indomethacin does affect the renal blood flow. I think Mohit and Kiran, who are good at assessing the flow, they probably would be better to talk on that. I know this was, but we used to monitor the urine output after giving indomethacin. Is there with Brufen also there is a little bit of nephrotoxicity, but not as much as indomethacin.
So we did one randomized controlled trial of indomethacin and IV paracetamol. So in that, this thing we noticed in the indomethacin group. And here, Dr. Steve has very nicely is also asked whether we should stop second and third dose of ibuprofen if the murmur disappears. So basically, he's been clinically correlating the murmur with the closure of the PD and this thing. But what we found was even when the dose unit output decreases, echo evidence did not show the closure of the duct. The duct was open. And we followed those group of babies with the creatinine also, creatinine and ammonia and urea and creatinine. And in the indomethacin group, the rise of creatinine after complete course was significantly higher than the other group. So it was basically hitting the renal functions, and there was no correlation of decreased urine output and dosage of indomethacin with the closure of the duct. And it was all echo-based studies. So it was in echo, the PDA was still open, even though the urine output decreased and the creatinine rise from the normal base level.
The reason I asked the question actually is because there are two studies. One published a few years back that showed that even Brufen actually, they said that proposed that urine output reduction can be an indicator of PDA closure. And this follow-up was done actually in PGI few years back as an MD thesis that showed that it doesn't really help. So it looks like that monitoring parameter may not be really helpful. I think
Again,
Kiran,
what dose? Yeah, I was just saying, I was just saying what dose. People follow 15, 10, 10. Some people do 25, 15, 10. So I think oliguria could be side effect more so than the effect. So, and as Dinesh mentioned, it's more so in indomethacin we have seen. So again, we are not seeing in the routine dose 15, 10, 10 when we are following, we are not seeing the oliguria as much as we used to see in indomethacin. So maybe one need to question the dose regime which they are following. If you're giving continuously higher dosing, then maybe, we need to check the protocol which you're following. So I don't know, in that raises the question, what protocol everyone is following in the unit for ibuprofen?
Yeah, normally, if I would share some experience, basically that if you look at the recent published network meta-analysis, there are three of them basically. So all three tend to reinforce almost same point that probably the higher dose Brufen is better than the standard dose Brufen. So, which is not 10.55, it is I think 15, 7.5, 7.5. That makes it 30 milligram per kg.
Total.
Not just, total. It's not 10.5 and 5. And they say that oral is better than intravenous.
Oral
But
is intravenous, yeah.
that part looks like
Okay.
it's a clear message that, and if you want to give Brufen, then probably high dose is better than the standard dose. So high dose is 15, 7.5, and 7.5. And oral better than intravenous. So that's the practice. So we have moved to the higher dose now. Maybe the last 6 months to a year. That's what we're doing.
Right. Any other have a different dosing anyone else is following? Because there are 3 different types of dosing which are reported. I don't know. Dr. Mohit, for ibuprofen, which one you're following?
Still the traditional, only in few patients. Like what we do is after 2 doses, we check the parameters. If the parameters are still the same, it is HSPD and the size is not, we increase the dose as to the dose what Dr. Venkat has just told. So instead of 10.55, like if we have to give 5, instead of that, we give 7.5.
7.5. So
This is what we do.
7.5, 7.5.
One important question that looks like we did discuss, Dinesh had pointed earlier also, probably is very important to see that, like fluid management. So fluid restriction is one way of managing fluids. Keeping dry, he used a word that keep the baby dry. So now keeping the baby dry means what exactly? What are the indications of the baby is dry now? So there are some questions on this. Fluid restriction, any protocol on this on day 1, day 2, and so on. And in relation to same, there is another question that, okay, if I did restrict the fluids, but it doesn't help, should I think starting diuretics? So if yes, then what is it? Is it a Lasix or a thiazide or a combination? There's one more question on this. So maybe we can have comment from everybody one by one. Maybe Dr. Rajesh can tell his experience, Dr. Surjit, Dr. Tejo, and Dr. Dinesh in this order. Dr. Rajesh, please.
Basically, fluid management, like if you are dealing with less than 1 kg baby, and the humidity is, as I earlier Kiran also told, humidity is the key in managing the fluid. And that way, if you have good humidity, like maybe 90-95% if you are giving, and maybe you may keep a baby little on lesser fluid. But if you have open care, then it's become very difficult to manage the fluid. That is one thing we have to really realize this thing. Like good humidification is very good for electrolyte as well as your PDA, both ways. And second question was?
No, like say, do you want to restrict the fluid? Like say, if the baby needs 120 ml per kg per day, whatever you go with day wise, you want to hold it to 100, 110, thinking that you want to keep dry. And how do you know that he is dry? Like, how do you understand that clinically that he is dry now?
Clinically, basically weight, we have to check. And other thing is sodium.
Okay.
Sodium is also a good marker whether what is happening in the intravascular fluid. If your sodium is a little higher, that means baby is little drier.
Okay. So now, have you ever used diuretics for managing fluids? Like say, the baby is not edematous, there's no pulmonary edema. So still, but you want to give diuretics to manage, keep him a little dry so that the PDA doesn't become significant?
If baby is symptomatic, we have pulmonary edema, then one or two sorts of diuretics.
If not, then no.
No.
Right. Tejo, about the maintenance fluid, you want to restrict. So
the concept is that the concept in fluid restriction is that you should not cross 150 if you are using the policy of fluid restriction. So usually between 120 to 150, you should try to manage your fluids. Of course, on day when you have to decide if you have a humidity management, then you can even start around 60 to 70 and then go upon it. By day 5, don't cross more than 150 is the main. That's what Cochrane also says about the fluid restrictive management versus liberal fluid regimen versus. Okay. So I will allow the other one point is that, as Dr. Rajesh also told, dry. What is meant by dry or anything? So we can allow the baby to have a little weight loss in the beginning. So if you have too aggressive fluid policy, maybe they will try to chase the fluid weight not more than 10% it will lose. But I will allow maximum up to 15, provided that the urine output and there is no increase in the acidosis and there is no shoot up of the sodiums too higher. Maybe maximum 12 to 15% I will try to accept, but beyond 15% we will try to provide a little more aggressive fluid management only for the baby, so that again there will be many other consequences with the hypertonicity of the fluid that will happen inside and hyperosmolarity. Again, that can lead to more IVH and other things. And coming to diuretics, definitely no on the diuretics, because diuretics, it will causes the intravascular volume to go low when there is a PDA without pulmonary edema, which we are looking at it. So when the diuretics we are giving, intravascular volume will go low. It can have the kidney to suffer a little, because again the renal perfusion will go lower, which can activate the renin-angiotensin mechanism, and then actually it can increase the size of the PDA, and then it can become a vicious cycle. That's what the physiology says. That's the reason why routinely we have not used the diuretic. Maybe in an established PDA where you are having the size 3 mm on to when you have the baby at 28 days of life and the baby is having minimal oxygen requirement and you just wanted to give a trial of diuretics, and those cases we tried to give the diuretics. Otherwise, in the initial phase, we haven't tried the diuretics.
Okay, good. So Surjit, the short response? What do you like, say, fluid restriction, yes or no? And diuretics, yes or no, in your practice?
Yes, like when we start fluid, usually at a 60 to 80 ml per kg on day 1, and then we increase by 10 to 20 ml per kg per day. And that is what we can restrict the fluid by around 5 to 10%. So that would definitely help for the PDA. And yes, unless and until there's pulmonary edema or there is overload in the baby, we don't start diuretics, especially to just to treat PDA.
Okay, Dinesh, Dr. Dinesh.
Yeah, I think, see, when you want to run it dry, it means, so usually in the first 2-3 days, in fact, what they do, some people talk about keeping between 110 to 130 ml per kg, not crossing 130. And see, unlike sort of sometimes in the very small babies, taking them out for weighing is also sometimes is very challenging, especially the 24-25 weeker, because they do get very cold when you try to do. And the incubator weight is also sometimes may not be reliable. So your electrolytes, your sugars, and your urea creatinine are the one which gives you a good this thing to say how much fluid to give. So compared to earlier when we used to say I want a sodium around 140, I think even 145 is okay, up to 150. As long as your urea creatinine is fine, you're not running too dry. As long as your blood pressure is not going too low, you're not running too dry. That's what I mean by not dry. Your urine output is maintaining 1 ml per kg per hour. You're not running too dry. This is probably what they mean by running your fluid. And then you probably look at what your ventilation parameter is. See, diuretics in the first week, you would only consider you have a PDA which is significant, but for some reason you can't give your medications. So that's when you always have this debate whether I should give furosemide or chlorothiazide. Furosemide, you have a concern that it might keep the patency of the PDA, and that's the reason people think about chlorothiazide. Otherwise, as a rule, you probably won't think about diuretics during the first time. Or suddenly you have a big pulmonary bleed, like what we thought about these things. You suddenly want to run dry, then you probably give a dose of diuretics.
Right. So I think the message is very clear and loud that furosemide, there is no role. Electively, there's no role. They don't give furosemide as a diuretic in general. So, and regarding the fluid management, we don't really go ahead and actually hold extra fluids, but probably if there is, you look at sodium as a monitoring parameter, and sodium little higher actually might help. Maybe around 145 might be helpful. So depending on the serum sodium, probably you can actually do some restriction, 10 ml, 15 ml per kilo per kg per day. That might help in the initial few days of life. Taking care of the dehydration component also, should not get into dehydration. So one has to be careful. And we know that scientifically the evidence also that you would give excessive fluids can lead to higher risk of mortality, BPD, apart from PDA. So it means that you always tend to keep them a little the drier side, but not dehydrated side. So it means that one has to do more frequent monitoring. And I fully agree, Dr. Dinesh, what he said, because weighing is not really a great option, because even though weighing is good, but taking them out or inline weighing. So even though we have all higher, sophisticated machines to do the weighing in inline weighing scale, but probably it has a certain lesser reliability. So I guess serum sodium might be actually a handy marker where you can repeat once in 12 hours or once in 8 hours, and you can try to manage accordingly. So that's what it looks like. I think we try to cover predominantly the questions. There are many repetitions, so which we did address to a large extent. So there are some questions on what about PCM infusion. It is mentioned in the AIMS NICU protocol. So yeah, some people use it as a PCM infusion because of better drug delivery, but you don't really have great amount of data on this. So many would still give actually as a 6-hourly intermittent dosage only. That is one. So again, one more question on early targeting versus prophylaxis. I think it was very clearly told that prophylaxis doesn't have a role in, as of now, in extreme preterm babies. Yeah, early targeting seems to be the most appropriate way of managing, considering there is a possibility of spontaneous closure also. So any more questions? Anybody wants to comment? Dr. Mohit, you want to say something on this?
For the time being, I think so. We have already overshooted by 20 minutes.
Yeah.
And a lot of this thing, but there are, the panel was really it was very interesting. I even enjoyed a lot because that was a real combination of experience in people doing echo and, the interaction of the thought process. So that was very nice. So it must have generated a lot, because there are 183 queries in total by 561 people. So it's generated a lot of this thing, interest. So, but after this panel, the query, I tell you, the percentage of queries just went up, and they are all very relevant queries, but still it will be difficult for us to answer each and everything. So now I've stopped copying and putting in the chat box, but most of the queries have been answered in this panel. So it was really very enjoying. Dr. Venkat, yes, please.
It again shows one thing very clearly, that so much is unknown about actually everything.
Yes,
That's why questions keep coming. Let the PDA be a common problem for what? So many decades. So
Very right.
I
Very
still
right.
remember actually Professor Anil Narang's bookshelf. We used to, when we were doing a DM, तो हम चोरी छुप के वहां जाके देखते थे, सर नहीं होते तो क्या क्या बुक रखे अंदर, उन्हें क्या पढ़ते थे वो. So I used to remember actually, used to have one book given by, I don't remember the author actually, when he was doing actually his fellowship somewhere in UK. It's a 180, 200 pages book actually, only on PDA. The book only on PDA written by him actually, and the book is published, actually given to him as a gift. So वो book का photocopy करके हम पढ़ते थे, मतलब maybe 15-20 years back. So a decade old problem, और आगे भी चलते रहेगा. So it's
But I think the summary was art of medicine, isn't it? Like everyone is a so passionate clinician. If you do things right in a good clinical way, then the babies will respond. You know, they will get benefit. So ultimately, it's coming to the art of medicine than the evidence.
I want to just say one thing, like this PDA is basically problem of less than 28 weeks baby.
Yeah.
Unless you take care of humidity, proper humidity, and you will not be able to manage PDA and fluid in first week of life. I have seen many managing on open care, really difficult to do it. So please take care of humidity in first week of life in babies less than 28 weeks. That makes our job much easier.
They lose less transepidermal water loss here.
Yeah.
Just to add, sir, now the availability of IV ibuprofen also is there in the Indian scenario. But at the same time, we should not be too aggressive on starting the PDA management. I think that's emphasized everywhere. But once the drug availability comes, then we have the tendency to start off the drug. And there are very good narratives from the Stanford group and many other groups also about even just exposure to the drug also, independent of having the PDA. Some of the short-term and long-term outcomes are not good. So we should just even keep that in mind, that anything in the brain development phase, whatever you are doing, we should think about the neurodevelopment and also the lung development as a marker for our final outcomes. Yes, sir.
I don't know. Since the
should we conclude? Mohit?
Yes, I think so. I think so. Yes, Dr. Rajesh, last comment. Please.
Like since the paracetamol has come in the practice, expectant management and aggressive management, I think is a trade-off between these two. People feel, okay, give it. What it doesn't have any side effects. But I don't know what side effect the paracetamol has. Still,
that might be a problem basically, because look at the paracetamol, no, all the study and even that Cochrane reviews on systematic reviews, it clearly say that we don't know much about paracetamol, what it does to the brain later. So it might happen so that down the line, so it might be a, like say, unsafer drug than brufen, and we all can move towards the brufen part and probably not treating also. Right. So let's conclude this. So thank you once again to Mohit and the team, Kiran and all, for the opportunity to all of us. So wonderful panel, and actually happy to be amongst all these great people. So who had actually great brains, great experience. So and given a chance to sit with them and moderate also. That is I'm lucky to be here. Thank you once again. Thank you.
Thank you, Dr. Venkat. Thank you, Dr. Rajesh. Thank you, Dr. Tejo. Thank you, Denisa. Thank you, Dr. Sujit. It was really nice. And now we have already taken most of the questions. Few are being left, but we can't help it because a lot of questions are there. So So I would like Kiran to please conclude, and I will just share the slide for the thing. Over to you, Kiran, please.
Okay, so again, first of all, thank you everyone. Thank you for all the panelists, all the speakers, and great thank you to Mohit, the brain behind initiating and organizing this, and driving all of us together. So first of all, and then the whole team in the back end who really help us to organize this. The idea was of the symposium was to again generate discussions and answer the common queries. Unfortunately, we missed Yogin and Arvind in the session. Unfortunately, some unforeseen reason they couldn't join at the last moment. But I think their topic has been well covered in the panel, which was a great. And the enthusiasm, great thank you to the audience, the delegates and the participant. I think we showed great enthusiasm in asking the question, and many of them stayed throughout the session till end. I mean, it's not easy to focus for 2, 3, 4 hours. So great effort from them as well. And I hope we could answer and we could clarify many queries. But a take home is that do clinical echo base and treat the baby bedside, and sort of clinical and the art of medicine, which we all were talking about. This all fine tuning about the fluid, the humidity, the ventilation, and the echo based management is all, once everything comes together, probably get the best outcomes for this thing. So I hope everyone enjoyed it, and we are working on getting this symposium better. We will come up with some more sessions in next couple of months. And as Dr. Mohit was showing this slide, we definitely are getting a lot of enthusiastic candidates who are joining us for the online ECHO program. Currently, the 4th batch is going on, and the 5th batch is starting in July, first week of July. And definitely the registrations have already started. A lot of people are expressing interest, and the enthusiasm is growing, I think, with the resident, the practicing pediatrician and neonatologists, not only in India, but globally. So definitely we are very happy that we are able to share our knowledge and help others. And the community, the hemodynamic community is increasing. And I think that is helping definitely the neonatology as a fraternity and hemodynamic fraternity. And we are just looking forward to, conduct more such events in future. So with that, thank everyone, Dr. Dinesh, Dr. Tejo, Dr. Rajesh, Dr. Venkat, and everyone who, Dr. Surjit, who have joined and stayed throughout the event. And really thank you, Dr. Mohit, again for making me also part of this whole thing. So over to you, Dr. Mohit, final comments.
Thank you very much, and see you in the next symposium, something like that, with the same. Would like to have this team persistently, because this team today is really, I enjoyed the whole presentation, whole symposium. I don't know about anyone else. I enjoyed it very much.
Yeah.
Thank you very much.
Thank you very much. Thank you. Great learning.
Thank you.
Thank you. Bye-bye.
Bye everyone. Thank you.
Bye.